Okay, that's done.
Okay, thank you. So good afternoon rather, and welcome to everybody joining us for July's governing body in public. There's a few new faces on the screen today, so just welcome them. So we've got Laura Garner joining us for the minutes and corporate secretariat support. Jenny Milner, who's here to support a paper, Danny Hydes in place of Alan Windle, and welcome again to Trish Edney, who is here on behalf of Healthwatch. So I will start with apologies for absence. So we've got apologies from Alan Windle, Chief Nurse, and he's got Danny Hydes here as his deputy. We've apologies from John McElwraith, Nikki Normington, Judy Robinson, and Trish is attending on, Trish Edney attending on behalf. Thank you, Greg, for joining us this afternoon. We've had some advance notice that you may need to dip off at an earlier point, so we've picked that one up, and thank you for taking the time to join us this afternoon. I can confirm that the meeting is quorate and we're all good to go ahead this afternoon. So before we start the meeting, does anybody have any declarations of interest they wish to make now in any of the items on today's agenda? Okay, so no declarations of interest above and beyond what is already notified to us on the declaration of interest register. I haven't been notified.
So could I just, we've had another apology from Lisa Phillips as well. It was a late one, just so you're aware.
Okay, thank you, Kath. So apologies noted there from Lisa. Kath, I can confirm we've not had any questions in from the public. No, okay. So I'll move us on then to opening remarks. I haven't prepared a chair's paper this month, given we've had quite a few governing bodies in rather quick succession, and a lot of other pressures on CCG workload in the interim. But there are a few things that I just wanted to draw out in opening comments today. First one is just recognition of the immense work that has been undertaken to contribute to the vaccination effort in Sheffield. So a big thank you to all of our GP practices that have been involved in that, local pharmacies and our partners from the teaching hospitals working through the mass vaccination centre, but also a big thank you to the local authority for all of the support they've done in being able to get us into some of the areas where vaccine uptake has not been so good, and there are a number of vulnerable people in those areas, and also a big thank you to local communities, local voluntary organisations that have really rallied around to make that vaccine programme as successful as it has been in Sheffield. The second thing just to pick up is everybody on the call will be aware of the immense pressures at the moment across the NHS, both in hospitals but also in general practice. So again, you know, a big thank you to everybody working across our system to ensure that patients are able to access safe care. Next item I want to go on to, so just wanted to give some huge thanks to two of our locality members. Gordon Osborne retired yesterday from his role as locality manager for Hallam and South locality, and Lorraine Watson from West locality is due to retire this month. So I really wanted to just say a huge thank you to Gordon and Lorraine, who have been a big part of our CCG for a long period of time, and have really supported practices on the ground through the localities. And, you know, that's a really integral part of what we do as a CCG, and it's a really important part of how our CCG functions, how the CCG brings that clinical experience on the ground to the decisions that we make here in governing body, but also how we support back into our partners there in primary care. So Gordon is not with us today, but huge thanks to Gordon, and Lorraine, who is with us on the call this afternoon. Thank you, Lorraine, and wish you both very happy retirements. So I can see some applauses going there, but thank you both. Okay. You'll be pleased to hear both roles have been appointed to, and our new locality managers will hopefully be joining us for our next governing body. Final thing, just to draw out, is Leslie and I met yesterday with NHS England as part of the system oversight meeting, provided lots of very helpful information to NHS England on some of the significant progress that has been made by the CCG over the past 12 months, and we're hoping that we will receive our narrative letter and be able to update governing body at our next public meeting. So that's it from me for the things I wanted to draw out this month, and I'll now move us on to item 5, which is the approval of the minutes of the previous meetings. So we've got 2 sets of minutes to approve here, from the 6th of May and again from the 20th of May, which was the governing body meeting we had to receive our annual report. So I'll start with the minutes from the 6th of May and take them page by page. If anybody has any corrections they wish to bring up, please raise your hand and we'll hear those comments. But before that, I can see a hand's gone up. So Nikki Bates, do you want to just come in, please?
Yeah, I was present at the meeting, the second meeting in May, but I'm not on the list. So just a correction there. Okay,
thank you. So minutes from the 6th, I'll take this page by page. So any comments on pages 1 or 2? 3 or 4? Pages 5 or 6? 7 or 8? Pages 9 and 10? 11 and 12? 13 and 14? 15 and 16? 17 and 18? And then finally page 19. Okay, I've not seen any hands go up for any comments, so governing body will accept those minutes as an accurate reflection of the meeting that took place on the 6th of May. Now draw us on to paper A2, which are the minutes from Thursday the 20th of May. So Nikki, picking up on your correction there, thank you. Anybody else have any comments or anything on pages 1 or 2? 3 and 4? And finally, page 5. Okay, perfect. So we'll accept those as an accurate reflection also. So I'll move us now on to paper B, matters arising. Recognising that we've got quite a busy governing body schedule this afternoon, I will only take the open matters arising unless there's something important on any of the others. So item 122.19, this was around a question from the public around staffing across our ACP. I believe the last update we received is still recognising some of the pressures we've got and some of the additional complications of system reform in the background. But Brian, is there any further update on that paper? I don't think the position has changed since the last update.
The position hasn't changed, Chair.
Okay, thank you. Item 3620, regarding renaming the boardroom. The last update we received in May was that this item should remain on the private matters arising, but there has been an approval for renaming, but we need to wait until we're back in the building before we can do that. So if we could just mark that item for closure, because it appears on both the public and private governing body matters arising. So we'll take that one off. Item 36/21, regarding the chief nurse meeting to discuss disability and additional needs. We have got an update from last month that the item had not yet been completed. I don't know whether Danny or Judy, do you have an update on that item at this stage, or is it still outstanding?
I believe it's still outstanding, Chair. Okay,
thank you. Item 50/21. We were going to be scheduling an item on future development sessions just with regards to some of the detail on the Better Care Fund. That's now been scheduled in the forward planner for October or December, and we'll leave that item open until we've had that discussion here in governing body. And then final open item is number 64/21. This was regarding a question from the member of the public, specifically relating to cardiac rehabilitation services. We do have an update on the matters arising table there, but Kath, could you just give us a very quick verbal update of where that item is?
Yeah, the complaints team has picked this up and is working with the commissioning lead to talk with, I think it's with STH around this, so that we've got a proper response, and it'll come back to governing body when we've finished that piece of work.
Okay, thank you, Kath. So we'll receive that assurance in due course. Thank you. Okay, I will now move us then on to item 7. So usually once we've got those bits of business out of the way, we like to hear a patient story. It kind of keeps our business here in governing body very real. And I'm going to hand over to Lucy Ettridge, our Deputy Director of Communications and Engagement, to introduce this item.
Well, thanks, Terry. So I'm Lucy Ettridge, I'm the Deputy Director of Communications and Engagement and Equality, and I'm going to introduce a patient story today. And it's a story of a woman called Azra. She's 69 and she speaks Urdu and Punjab. And her story today is a video, but it's really a series of still images. And it's narrated by a worker at ShipShape. And actually she shared her story with ShipShape, and they're one of the 26 organisations that we've given money to help encourage people to have the vaccine. So it's Azra's story of actually her initial hesitancy and her experience of working with ShipShape. So bear with me while I multitask and try and play the video. Can people see that? Oh.
Yeah, it's just come up, Lucy.
All right. There we go.
Lucy, would you be able to press the little speaker button on the bottom of the YouTube video so the volume comes on?
Sorry, yeah, I'll start again. And I'll turn it up.
My name is Azra Baker, and I'm 69 years old. I speak Urdu and Punjabi.
Can people hear that? Probably can't, can they? Oh, sorry, and sound.
So, Lucy, if you're able to stop sharing your screen and then reshare it, there's a small tick box on the screen sharing that allows the audio to be shared directly from your browser. It might make it a bit louder for us.
Okay.
And the pandemic has made it more.
Let me practice this, right? Okay, going again. Right.
My name is Azra Baker, and I'm 69 years old. I speak Urdu and Punjabi, and I struggle to understand, read and write in English. After losing my husband, I have been isolated for many years, and the pandemic has made it more difficult for me as I feel even more isolated. I do rely on my family when I need anything, particularly during the pandemic. The last few months when the vaccine rollout started, I was told by my family and relatives not to have it, so I never booked the appointment. people in my community said that the vaccine was not halal, it's not safe, and it hasn't been tested. This went on for a few months. I was hearing a lot of mixed messages. I didn't know whether it was right to have the vaccine. When I started to get a number of letters and texts from my GP to book my appointment, my daughter said, "Mum, I don't think we should make the appointment," so we decided to ignore the texts. It wasn't a few months ago when I was at home and there was a knock on the door from a group of community engagement workers and community health champions who were from Shipshape. They came round to the flats to let people know about the activities that were starting up at the centre, which wasn't far from us, and asked us if there was any support that we needed and if we had any questions about the vaccine. A few of us asked a number of questions about the vaccine and there was some information shared. We joined the WhatsApp group, but it was difficult to understand what was right and what was wrong. After joining a few of the activities, which were going out for walks with staff and volunteers, there were other women within the group who I joined the walk with. At the end of the session, we had a conversation around vaccine. We had the local imam there and we had a few local respected members of the community who talked about the vaccine and how they had had it done and how they have been absolutely fine with it. I didn't respond to anything in the group and I sat very quietly because I had made my mind up that I didn't want the vaccine. After a few sessions, we had a conversation about what was in the vaccine and how it wouldn't kill us. One thing that really stuck to my mind was when the imam said the vaccine would save you and couldn't kill you, but if you had COVID, that would kill you. At the sessions, Shipshape showed a number of videos from imams, GPs who were local. One of them was my GP, who talked about vaccine. Shipshape were great in translating that information, which really helped to understand the importance of having the vaccine, but it also allowed me to share and correct the misinformation that was sharing within my family household and with our wider family relatives. I did book another appointment to see if I could speak to the imam separately. I didn't want my neighbours finding out that I was asking too many questions. Shipshape did arrange this for me and my daughter joined me within that conversation. After leaving that conversation at Shipshape, me and my daughter both decided to have the vaccine, and we realised that for months we had been listening and relying on misinformation that was shared within our communities. My daughter couldn't get time off work and I was anxious to go on my own. So Shipshape arranged for one of their community health champions, they called them, to arrange the appointment and take me down. I had never had the experience I had at the vaccine clinic throughout the pandemic. Everyone were lovely. They supported me. There were even volunteers from Shipshape at the clinic, which made it even more comfortable and put me at ease because I had already met them at the activities I went to. Now, a few months down the line, I have had my second vaccine. My daughter has also had a second vaccine. And my son, who was very anti-vaccine, has now also had his vaccine. And the thing that really made an impact and made us change was information that was shared and translated and made very simple by ShipShape. I am now probably one of their oldest volunteers who's spread the message out into the Pakistani communities, particularly my family, my neighbours and my surroundings, who decided that they weren't going to have the vaccine and they were fine. Because I have had my vaccine and my daughter has had her vaccine, they have realised that we are absolutely fine, and that has encouraged them to have their vaccine. So since we've had our vaccine done, there's been 8 other family members and relatives that had gone and made their appointments and had their vaccine.
So I hope you'll see from that one story the impact that the community organisations are having on individual lives and family lives, and hopefully the health and safety of the wide population. So ShipShape are one of 26 organisations that we funded to overcome hesitancy and barriers, and they're all doing a fantastic job. And I know Sandy's going to present the operational plan. I think it's the next item, which talks about, you know, we need to fund community and voluntary sector organisations in a more sustainable way. So thank you very much.
Thank you, Lucy, for sharing that video. And thank you to everybody involved in making that. Really important story there about working with communities. But I'd just like to take any comments or reflections from governing body. So Chris, please.
Sorry. Yeah, it's really shows that that real community engagement in action at that level, and because there's the trust there between both the practice, the people that are working from the local authority, and also particularly ShipShape, because it's peer education, it's someone like me, and it's credible, and you can see that in action, and it builds. It may seem a small thing, but it has an incredible impact, and I've seen it work at lots of our communities across Sheffield, really, because you've got that trust in people and that understanding, and also really listening to what concerns are and having those conversations. And I think we have got such strong partnerships with community organisations like ShipShape and our GP practices. So I'd just like to recognise how powerful that approach is and how much it makes a difference. Thanks.
Thank you, Chris. David Warwick, please, and then Greg Fell.
Hi, I'm David Warwick. I'm a GP. So I'm really pleased that, because sometimes when we hear a patient story, it's where something's gone wrong and we need to talk about how we need to make it better. And there's always room for improvement, but I'm really pleased that this is a story of something having gone well. And whilst, you know, there's just as much potential for vaccine hesitancy in all neighbourhoods and communities, I think that some of the central sort of government and NHS stuff might be tailored towards the majority in terms of, you know, culture, ethnicity, things like that, language. Yeah. So I'm really pleased that locally we've got this effort to take into account cultural issues, including issues of, you know, ethnicity, religion, language. Really good. So we can always improve, but I'm really pleased that that we're doing, and I want to recognise the voluntary sector that's really been invaluable here, and we've had discussions before, and we'll continue to have discussions about working closely as partners with VCF sector colleagues and yeah, roundtable. Thank you.
Thank you. Greg, please.
I'll be quick. Echoes on a theme. So just worth us all bearing in mind that Sheffield is still the leading of the core cities vaccination coverage wise. So well done to all those in Sheffield that made that so, because it hasn't happened by magic. There is still a gap between East and West, between Black and Asian and white. Let's not hide away from that. That gap is significantly less than it would have been left to the path of natural default. And again, that hasn't happened by magic. And that story that we've just heard can be echoed across the city. Again, as I think as Chris said, it kind of really underscores the importance of investing in local relationships, because there's no point giving me or Zach a megaphone and getting us to stand outside 722 or the town hall. Has to be done locally, and that story has demonstrated that does pay off and have success.
Thank you, Greg. Although I'm sure if you and Zach were outside the town hall with a megaphone, you may muster up a bit of business, but definitely not as good as that community effort. Okay, final comments then from Mark Gamsu and Nikki Bates, please.
Yeah, I think I was heartened to hear also the mention of community health champions, which has been, this city has given a commitment to over, I would certainly more than 10 years, I can probably say decades actually. But it's continued, sadly, this work led by a team in the local authority. It's continued largely under the radar. And I think it's really important that as a sort of health and care system that we recognise the potential of community health champions and support ways in which they can be engaged and utilised. So I think that's really heartening. I think the other sort of marker I put down, and in the private part of the meeting, I know we're talking about a paper coming from the Accountable Care Partnership, and I think we really need to continue to affirm the role of the voluntary community sector and the importance of things like community health champions going forward. And I apologise, I didn't say that I'm Mark Gamsu, I'm a lay member and deputy chair of the CCG.
I didn't say who I was as well. Chris Neal, lay member. Sorry about
that. Nikki, please.
Nikki Bates, GP at Portsbrook and also governing body member. Just to say that ShipShape have been absolutely fantastic with the vaccination effort in our area and at Portsbrook, and just a shout out for them. Really, they have been fantastic. Thank you very much.
Okay, thank you. So, as always, Lucy, could you pass our thanks from governing body on to ASRA, and just say thank you for that really insightful video. It's been really important for us to hear some of the impacts of all of those efforts in that local community. So, okay. Right, next item then on the agenda, we're now moving into papers for approval. So item 8, and it's paper C in your noting pack, is the 2021-22 NHS Sheffield CCG operational plan. Governing body is being invited to approve the operational plan, and I'm going to hand over to Sandy Buchan.
Thank you, Chair. So my name is Sandy Buchan, I'm Director of Commissioning Development, and I want to present the CCG's operational plan for 21-22. And as Lucy said, I hope people can recognise throughout the plan that our Sheffield population is absolutely at the heart of what it is that we want to do and intend to do and achieve and deliver in 21-22. So the plan itself details our priorities and commission intentions for the coming year, and really incorporates the first joint commissioning plan which has been developed between ourselves and Sheffield City Council. So rather than go through each slide within the plan, what I would like to do is pull out some key points from each of the chapters. So chapter 1 details who we are and what we do. So our vision, working with you to make Sheffield healthier. It was the same vision in previous year and remains fit for purpose, as with our objectives in terms of what we want to achieve and deliver as an organisation. It states our challenges in terms of what we face are against in terms of against within our population, and the principles in which what guides us and how we're going to deliver and achieve our intentions and programmes of work. Touches on our joint commissioning relationship and that development of the joint plan, which I will go into detail a bit later on, as well as the Accountable Care Partnership priorities. And there is alignment between those priorities and the work that we're doing within our joint plan. One of them being mental health crisis, which we will have a presentation on shortly as part of the agenda. Chapter 2 talks about our ongoing response to COVID-19, and it really touches upon how we've come together as a place during the pandemic, looking at lessons learned, looking at those things will continue. And our partnership working across Sheffield Place really has been a positive driver throughout that pandemic, and including the citywide groups, which I know Greg's on the call, which is great in terms of him leading that, as well as the outbreak surveillance, etc. Also the establishment of our long COVID service, which really is an exemplar of co-design with those people who have been suffering from long COVID symptoms. And as we've touched upon already, and with the patient story, the COVID vaccination programme. And really, can I plug the primary care networks and primary care as a whole, the volunteers and all organisations who have been involved in the vaccination programme really has done exemplar work and done a fantastic job. And Greg did steal my thunder when I was going to say we are the leader of the core cities in terms of the percentage of our population being vaccinated both first and for second doses. So it really is a fantastic achievement for Sheffield, and a really good big thank you to primary care for that. Chapter 3 then looks at the restoration of our services. So it has impacted on our services during the last year, and as part of the national guidance and planning guidance, really looks at how we're restoring our elective surgery, really looking at how cancer services and waiting times and all the other services, and what it is that we are going to do and achieve, and work with our Sheffield partners in restoring our services back to pre-COVID levels. So really an emphasis on working together to look at reducing our backlog and getting those services back to what they were. Chapter 4 looks at priorities for quality and safety, and again the quality team within the CCG have done a fantastic job within the last year, really making sure that our quality of services are provided still of high quality and safe for our population. And this chapter really just focuses on the priorities within our quality assurance, quality improvement, safeguarding, CHC, continuing healthcare priorities, with a real focus on care homes, which has been a focus during the pandemic. And also looking at our digital strategy going forward, really making sure that those who need access and digital exclusion really is we're focusing on making sure we've got digital access and our estates. So really focusing on the quality of what it is we want to make sure we provide. Chapter 5 is our commissioning intentions and commissioning plan, and I've said the details the first Sheffield joint commissioning plan across health and social care, with priorities being within communities, voluntary sector, ongoing care, children and families, mental health and learning disability and frailty. And within that joint plan, we've identified 31 commissioning intentions, 19 being within that joint space and 12 being CCG specific. And there really is alignment throughout the chapters. So those specific ones that are related to the CCG being about the restoration of services, and the joint ones really aligning to our accountable care partnership priorities and really picking up what we need to do as response to COVID, etc. So really does have alignment throughout the whole the plan itself. There's also a golden thread in terms of reducing the impact of health inequalities, which we know have been exacerbated through the COVID pandemic. And it really shows our commitment to what we want to do in Sheffield to reduce those health inequalities and have an alignment to the Health and Wellbeing Board. As a CCG, we acknowledge the 3 main areas we really wanted to have an impact on: those areas deprivation, population of some ethnic minorities, and those people experiencing homelessness. So our commission intentions all have a focus on reducing the impact of health inequalities as they're being implemented. And underpinning all of that commissioning plan is our Sheffield-wide outcomes framework, which is currently being developed and really has the heart of our population's voice at its centre. So we're using population health management, service metrics and performance indicators, but the absolute key point of this being feedback and having engagement with the population to really understand whether or not the changes that we put in as part of our commission intentions is having the right and required impact and that they can see it. So really setting up those delivery of outcomes. And this is something that is now being developed across Sheffield and really has both providers and commissioners all focusing on the outcomes of our services. So really is an important change and factor within our operational plan for this year. Chapter 6 focuses on us as an organisation being a caring employer. And again, I have to acknowledge that staff within the CCG have done an amazing job in the last year throughout the pandemic. And this chapter really looks at how we support our staff, how we develop our staff, and how we continue to use our listening techniques to really help manage the changes that we're going to be experiencing across the CCG, but really having them at the centre of any changes that happen. And then talking about those changes, Chapter 7 then looks at the transition to the ICS come April 22. This really is a change in landscape, and what I've put in the plan itself is the journey to date, where we've been working as an ICS over the last 5 years, and the transition into the ICS as a statutory body come April. This may change, changes seem to happen quite a lot. So this document will be a live document over the next year to really capture those changes and make sure that we're embedding everything that's needed for our staff, the organisation, the function that we do, and our position within Sheffield Health and Social Care going forward. So they were the key points that I wanted to present to governing body. The full plan has been submitted, so you will have it as part of your papers. What I do propose is that we provide regular updates in terms of the delivery of our commission intentions as part of the performance and delivery plan. So really we can monitor and make sure that we are having that required impact and delivering what we've said we want to deliver for this year, with that outcomes framework really being a poignant part of our monitoring. And as I've said, it will continue to be a live document for the remainder of this year. So that's all I wanted to draw out, and I'm happy to take any questions.
Okay, thank you, Sandy, for that paper. I just wanted to thank Sandy and everybody who's been working on that, because this item has been through governing body a few times now, really as part of an engagement approach to make sure that we're not presented with a final plan, and that everybody has been able to contribute meaningfully to that. So just want to recognise that, Sandy, and thank everybody on behalf of governing body. Does anybody have any questions they want to pose to Sandy at this stage? I think you're off the hook, Sandy, and I think that is just a reflection of the level of discussion that the governing body's had over this paper over the past few months. So thank you, everybody. I believe we are approving that operational plan. Thank you very much.
Thank you.
Okay. Item number 9, paper D in the noting pack, is the appointment of nominated trustees to the Talbot Trust. And I'm going to hand over to Kath Tilney, please.
Thank you, Terry. So I'm Kath Tilney, and I'm the Associate Director of Corporate Services at the CCG. Some of you will remember, most of you will remember back in March, governing body approved the extension of the appointment of Dr. Zach McMurray as a nominated trustee to the Talbot Trust. So I'm coming back again with a similar item. Just as a quick reminder, the Talbot Trust is a grant-making registered charity that distributes funds to support the health-related charitable work for Sheffield, and included within the paper are examples of the kind of funds that have been distributed. This has been an arrangement that's been in place for a number of years, and Sheffield CCG has got the authority to nominate 4 of the 8 trustees for a term of 4 years to serve the trust. And so the trustees themselves bear the responsibility for the work of the trust and are responsible for their own actions, and as a body to the regulator, the Charity Commission. So what I'm asking for today is for governing body to approve the appointment of Mr. Sam Caldwell as a CCG nominated trustee for the period of 26th of March 21 through till 25th of March 2025. I recognise this date is actually in the past. This paper has been around for a while. It came just after our last governing body, and I think timings have just, it's a little bit odd, but anyway, I'm sure you can understand that. So last time we obviously all knew who we were talking about. I don't know how many people actually know Sam. Then everybody knows everyone in the health service, so some people may, but we've got a bit of background about him in the paper just to help. So his role is, I'm assuming it is a him, isn't it? Yes. So he's a head of grants at South Yorkshire Community Foundation, and has got 15 years experience working in the community sector, specialising in grants. Bit more information in the paper, which you've all seen. So really just asking today for approval for the appointment.
Okay, thank you, Kath. So noticing there's not a huge amount to debate there, I'll take a few brief comments. So Mark, please.
Yeah, of course, I'm happy to approve this, but can I just, this is slightly tangential. The Talbot Trust, I think, is probably, I'm guessing, is probably smaller than the Sheffield Teaching Hospital Trust. That's the way these things tend to go. And then sometimes there's also the South Yorkshire Community Foundation. And it does strike me that we've never really had a discussion about our relationship with some of these players. And particularly with regard to the Teaching Hospital Trust, NHS England has changed its view about the role of hospital charities with regard to promoting things like social prescribing and community anchor organisations. And I'm not sure that we are cited on that in Sheffield. So can I make a request that it may be that it doesn't apply to us, it certainly applies to other teaching hospital charities who NHS England has basically decided we're going to give some money to the teaching hospital charities, ignore organisations like community foundations who've got very well established links with communities, and get the teaching hospital charities to do more work engaging with communities. I do think as a CCG we should be cited on this and have a position.
Okay, thank you, Mark. Could I ask, probably this is one back to Kath at this stage, but could we investigate that a little bit more so that we can bring that back to governing body for further discussion in due course? So thank you for raising that, Mark. Jackie, please.
Sorry, I was just going to volunteer to take that action forward, given our relationship with the charity. So I'm happy for that to be me.
Okay, perfect. So Jackie to pick that item up. Are there any further comments before we approve the nomination? Nope. Okay, Kath, if you could inform the Talbot Trust governing body approves the nomination there of Sam. Okay, so on to papers for consideration now, which is item 10 on the agenda, paper E in the noting pack. I'd like to welcome Heather Burns, the Assistant Director of Mental Health Transformation, and Chris Taylor, Crisis Care Programme Manager, to take us through a little bit of a deep dive on some of the issues that have been flagged up with mental health. So over to Heather, please.
Thank you. So colleagues, you've had a presentation. I'm just going to ask Chris to share that, his screen, so that we can look at that together, and we'll go through a few items. We've presented some information to governing body before, so what I just wanted to do is remind governing body colleagues of some of the issues that we've raised previously, tell you the work that we've been doing through the crisis care programme that Chris has been leading as programme manager for, and also tell you the things that we're still wanting to do. So if I just start off with thank you, Chris, the second slide. So some of the background information here can be summarised by increasing demand and complexity, capacity of the systems, both for children and adults, to respond to that increased demand and complexity. Issues around workforce, retention and recruitment, system issues around relationships between providers, where gaps in between systems don't quite fill and grow together to fill gaps. Those gaps that exist around commissioning that will be addressed through long-term plan. And then some sort of specific issues really that have arisen partially through the pandemic period around staff availability and service availability, with certain services being kind of reduced in terms of their ability to open, and capacity around the staffing issues over the pandemic for those services. And then some things that are inevitably around the current sort of back to good work that the Care Trust are doing, and their journey from the CQC response that they had earlier in the year. So those sort of themes are, if you like, the underpinning causes around the breaches. And the type of breaches that we're talking about are, as I've said, both adults and children. Usually it is around complexity or awaiting an onward bed placement. So usually those are the two kind of major issues, and particularly for children and young people, that's waiting to go into a Tier 4 NHS England commissioned bed, where somebody may well be sectioned within the teaching hospital and then can't be moved until they've moved into an appropriate placement, but sometimes finding those placements with national waiting times and lack of capacity can be several days. We did have, and the other thing to point out is this isn't just about people with a mental health condition. It can be people presenting with severe behavioural disturbance arising out of learning disability and autism. And two of the longest waits that we had would be people that fall into that category, one child, one adult in the last 12 months. So there's sort of work that, if you like, goes beyond the work of my team in the mental health team, that also overlaps with the children's portfolio, and we will be doing work with them and are doing work with them on that. So just move us forward, Chris, please. So some of the service improvements that have happened since May, SHSC, the Sheffield Health and Social Care Trust, don't have a full 24-hour crisis home treatment team. We went early with a 24-hour mental health liaison team at the emergency department of STH, but in terms of recruitment to the crisis home treatment team, that, if you like, is the gateway or gatekeeper into ED. They've not had a full team. They're now recruiting, and apologies, I've put that they're operating until midnight. That's actually until 10 p.m. They're aiming to go to midnight shortly, but they are in recruitment to go to that 24-hour service. So that will be is already an improvement, and will be a significant improvement to where we were last year. SHSC, I mentioned earlier, that's some of the services that have kind of pulled back through the pandemic. The Psychiatric Decisions Unit closed for a period during the pandemic from November onwards, but had been only partially open. That is now open 24 hours a day, 7 days a week. That unit helps us to avoid people going into A&E, particularly people that are often repeat attenders. And it also gives the psychiatric services and mental health liaison team a place to assess somebody or to just de-escalate. So that's an improvement since May. The SHSC have an issue with some of their beds. So their bed capacity has reduced, and that's partly in response to the CQC rating and instructions around improving their bed stock and improving gender safety, and improving the kind of dormitory provision that they've had. So there has been a planned programme of work which has been somewhat delayed by NHS England's involvement with their Back to Good journey. But nevertheless, those improvements are really necessary, but consequently there has been a reduction in bed stock. And so SHSC have been relying more on out-of-city bed placement. That isn't unusual. Other cities have also had to do that due to the demand increase, particularly over pandemic. But it's fair to say that for SHSC, this is quite a change, because they've been nationally leading that for a number of years on having the lowest number of people placed out of city. So that has been quite a change for us. But SHSE are going to procurement to an out of city bed offer where they will have kind of planned capacity rather than ad hoc capacity. In terms of children's provision, we've been working with the Children's Hospital to get a 24-hour children's helpline, and that is going to be partnered with Rethink. The Children's Hospital themselves are doing that over this period until July, and that will go 24/7 from August with the voluntary sector. And then we've now appointed some young people's complex needs key workers, and they will pick up some of those children that I just mentioned earlier, particularly with learning disability autism, when they do present in crisis and with some really quite complex needs. In fact, a member of my team was just doing a care and education treatment review meeting this afternoon for a child, and a professionals meeting for a child in this situation. Move us on then, Chris, please. So there's also been some process and protocol improvements. I think I mentioned earlier that thematically, one of the things is about system changes or gaps where maybe systems weren't working optimally together in terms of their understanding of how they in each organisation operated systems. So we've done a lot of work on agreeing a protocol between organisations about who does what, when and how, and also to develop an escalation process, because that wasn't as efficient as it might have been in terms of how and who gets involved in when a person is looking like they're going to breach. So that's an improvement. And SHSE now do have a system for identifying and monitoring that. They weren't reporting that to us. We were finding out when we got breaches via the teaching hospital. We have something called proactive case management meetings across the children and young people services, and people are really reporting positively on that as a multi-agency, multi-system way to again manage some of those children arising with complexity and often in crisis. It isn't going to stop the crisis, but it gets systems working together to come up with solutions rather than the only solution being A&E. So there's a number of those improvements there. And then for us as commissioners, I did say there were commissioning gaps. One of the things that we're aware of, that there's not a safe space, de-escalation space for children. So we're about to pilot that as a community offer, which will run alongside existing services. We've extended Cooth, which is an online counselling service. We're working with voluntary sector providers. So it's interesting, the comment earlier about the role of voluntary sector. I think this is going to be key in us helping to unlock some of the barriers that we've got out there in community services. So we're working on a system of crisis buddies across children and young children and adults, older children and adults. And then a number of other things around extending work around identifying Section 12 doctors to help us with the Mental Health Act assessments. And we've significantly made offers to both SHSE and the Children's Hospital around how they would respond to fill in some of those commissioning gaps. So at the moment, because we've got two emergency departments, we've got the children's and adults, of course, the teaching hospitals. We have a mental health liaison team that will work with 16 and above at the emergency department at STH, but don't feel fully comfortable with that offer and fully comfortable and skilled with working with children with complexity. But the Children's Hospital aren't commissioned to do that either. So we're just trying to work with both partners to see how we can fill that gap and bring them together. And then I think significantly we've got commissioning capacity in the children's portfolio now for learning disability and autism, which hasn't been there before. And as I mentioned, this isn't just about gaps around mental health services, there are those other populations too. So thank you. I want to just mention a few of the barriers to progress, which has kind of come out in some of the things that I've said, but recruitment and retention is absolutely one of the number one issues that both our mental health providers are facing. They repeatedly go out to recruitment and cannot recruit. So there is something there that we're trying to look at around their ability to attract to the city. Just to give you an example, we heard that Wakefield had been offering a £30,000 supplement to attract CAMHS consultants into their area. So of course, there's a system issue here around workforce. There have been some strained working relationships, and we kind of feel that we go a few steps forward and a few steps backwards on that. But broadly speaking, I think the system is working probably better than it was 18 months ago. I've mentioned some of the gaps in services. I've mentioned increased complexity, and particularly eating disorder presentations over the last year have led to a number of delays for people getting into the right Tier 4 and NHS commissioned services for children. And then some of those services not operating, again linked to the staffing issues. So Section 136 suite at the Children's Hospital currently closed. I think just the other barrier to progress is a system one, and it's just the scale of the changes required across multiple systems: education, children's social care, looked after children, as I said, autism, mental health, learning disability. So it's a really multiple. When does crisis begin and prevention and early intervention stop? And where is it that some of the services are kind of not quite delivering what we need them to do, which is leading to crisis? So the fix ends up being bigger. And then finally, the kind of waiting list size. So both organisations are struggling, as I said, with capacity demands and workforce. So I want to hand over to Chris now as the programme manager to just give us a canter through the kind of programme and what we're trying to achieve and some of the objectives. So we won't go into a lot of detail, but just to give you a flavour of the work that we're doing to address some of those specific issues. So Chris.
Thanks, Heather. Afternoon, everyone. As I said, I'm Chris Taylor. I'm the programme lead for Sheffield Old Age Mental Transformation Programme for crisis care. So I came in March, just before COVID hit actually, so it's other than a couple of weeks, it's been pretty much virtual working, which has been a challenge obviously in itself, but I think we've made some really good progress. So I'll not go into too much detail, so we've got time at the end for questions, but I'll run you through some of the work we've been doing. Just to say as well, I've got a wife and 3 kids downstairs because we're all self-isolating until my son gets his COVID test results. So if anything kicks off, I do apologise. I've asked them to be on the best behaviour. So one of the things that we did last year in August and September was we did quite a thorough engagement of frontline staff, the voluntary sector, people with lived experience, and we co-produced this, what you can see on screen, which is the future state vision for crisis care. We're working towards a lot of these areas. So these were the things that people reflected back were important to them, and that we either needed to bolster if we've currently got it, or we needed to put in place. So we're working towards these, and a lot of that work's being picked up through the work streams, which I'll come on to shortly. I think that some of the key things to draw people to on this, because it is a little bit busy, there's 12 different design principles on there. 6 of those are person-centred, and 6 of those are around the infrastructure. And again, the writing's quite small, but I think they're really key. And the idea is to keep coming back to those as we design the new model to make sure that they're sort of integral within the model. Some of the other things to pull out really. The front end infrastructure is kind of what patients touch on, etc., and what staff use. The back end infrastructure are things that support and enable things to happen. Some of those are being picked up on a wider regional basis now, and I'll come on to that as well. So one of the things that we're really keen on when we set the programme up was to make sure that the governance was really robust. So we've got a cross-system executive programme board that includes the voluntary sector. It's got execs from all the trusts. It's got YAS and South Yorkshire Police involved as well, and we're looking to get a GP involved in that board as well at the moment. There's also a design group which meets fortnightly, which is made up of clinical and managerial colleagues from across trusts and across the system. The idea of that is to kind of validate the design and make recommendations to the work streams. And then we've got the work streams that are kind of doing a lot of the design work and will enable a lot of that delivery to happen very shortly. I'll move on to a little bit about the work streams. we're straight onto workstream 2 here. Now, workstream 1 was set up, but is a lot of that work has filtered into the other 4 work streams now, because it was to look at the priorities across the system. Some of this Heather's touched on in the commissioning gaps, but one of the things we're looking at under workstream 2 is how we can bolster the liaison team, and what different roles we could benefit from within that team. And then the 16 and 17-year-old crisis care safe space, we've got a sum of money to be able to pilot something for that, and we've got 2 bids from providers that we're actually considering at the moment. So we shouldn't be too far away from putting something in place there. And again, that's to allow 16 and 17-year-olds time in a non-clinical environment to de-escalate when they're in crisis. Workstream 3, some really great work on this workstream, and it's really firing on all cylinders. This is about the accessibility to services and the quality that's provided for crisis care in the city. One of the things that shone through from the engagement was around people who keep coming back into crisis, not having to tell the same story. And one of the things that we've developed through that is a crisis passport that we've worked with Chili Pep on. So the costings have actually now been worked up. So we're at a point where we can take that to board. Another really big area that we're looking at is alternatives to crisis care to formal services is the Crisis Cafe and the Crisis Buddies peer support model. So again, that's in development, and we're very close to finalising a spec and being able to go out to market on that as well. We've also got some funding for that work as well, so hence that being a priority. There's lots of other great sort of enabling type work happening. One of those things is the crisis care stories. So we're pulling together case studies and pen portraits of people in crisis across the city and anonymising those. And the reason for that is to sort of validate the model as we design it and check for gaps. Workstream 4, improving communications and awareness. That's kind of got a dual role, partly to do with the internal programme and partly to do with letting people know about the new services that we're putting in place. We did release an internal Comms Mental Health Awareness Week, which is in very plain language and again, I think really useful. So I've had a number of people contact me off the back of that as well, which is really good. We've also undertook a survey to map where people in crisis are referred to. That got over 250 responses from across the system. And again, we're looking at analysing that data to see how we use it. Workstream 5 started off where we were looking at developing a data and intelligence dashboard, specifically for crisis care in Sheffield, and then looking at shared care records and digital ways of working. The shared care records and digital side of things is actually being picked up by SYB colleagues now. So we've informed that work through our clinicians in Sheffield, but we're now focusing on how we can develop a really sort of intuitive and user-friendly data and intelligence dashboard, which shows a full picture of crisis at hopefully at any point in time. I'm not sure how real time we can get that, but we're exploring what we can do around that. So that's really a flavour of what we're doing. So hopefully people have got some questions for us, and I think that's the next slide. It is. Thank you.
Okay, thank you, Heather, and thank you, Chris. I propose we probably have sort of 8 to 10 minutes of questions and comments, just to keep us on track with the agenda. But does anybody wish to bring anything up? So Mark, please.
Yeah, thanks, Heather and Chris. And, I really welcome this determined effort to try and take a holistic citywide approach with regard to this agenda. And I know that I think both of you have been to the Speak Committee a number of times. Obviously, with the pandemic, it's particularly difficult getting voice. I mean, getting the voice of service users is much harder, and getting the voice of people particularly who experience crisis care, is difficult too. So I think it's hopeful what you've talked about with regard to the crisis care stories. And I suppose I've got 2 questions really. One is, what's the relationship that you've got with Care Opinion with regard to that generally? Because obviously as a leading organisation that is based in this city, that seems to be a real opportunity. But secondly, we received some data from you in terms of the number of individuals with lived experience who've been involved in the programme thus far. And for the reasons that I've said, the numbers are not great. And I just wondered whether you had plans with regard to trying to strengthen that going forward.
So I think, Care Opinion, we probably need to have another look at actually and make stronger links. So we do get a lot of feedback through the voluntary sector providers. So we've got Colette Harvey that we employ through Mind to lead the voluntary sector providers of 42 people, and we're about to relaunch the Mental Health Partnership Board, which will be called the Mental Health Collaborative, as a way to get greater voice. In the workshops itself that Chris alluded to earlier, we actually did pretty well getting voice in, because what we did is we went out to service some of those community groups and asked them to speak to some of our people in the city that have experienced services. But I think it's something that we're on a continual cycle of trying to improve that and trying to reach out. So Chris has been, for example, to the Autism Partnership Board. He's been out to other groups. Members of my team sit on those partnership boards so that we're feeding information back in. And in fact, I was there yesterday at Autism Partnership Board with Alexis, where service users and family members were sort of saying, you know, here's our experience and feedback about accessing mental health services in crisis. So I agreed yesterday, and I've not told you this yet, Chris, that we'll actually do a specific deep dive around autism, because whilst this programme started, as we said, with mental health, we can't forget that people don't fit into nice boxes and that other people are going into crisis. So, but inevitably then this programme's getting bigger and bigger, but nonetheless, that is a commitment that we're looking at, and the needs of people with dementia in crisis too, because that also falls under our team. So I think
can I just build on that, Heather?
Yeah, sure.
Work stream 3, Mark rightly said, we've been to speak a couple of times, and it was a really thorough engagement and co-production piece of work that we did. I'm not just saying that. We got a co-production partner involved, co-creator who were really good and sort of really innovative in the way that we approached it. And we did speak to a lot of the different patient groups and different cohorts across Sheffield. And again, in workstream 3, that's led by the specific work on the pen portraits and the crisis stories is led by Bev Wright and Sarah Neal as well. We've clearly got links across sort of quality and different networks. And the other piece where that links closely to that, what we're looking at, is around feedback loops. So we know that there's all different feedback across the system about crisis care, and we're looking to pull that into one place. So it's easy to pull themes from it and understand actually, you know, what do we need to do across the city when it comes to crisis care. So we've got that in mind, and there's a number of different pieces of work that need to connect really for that to happen. But
that's really helpful. And sorry, Chair, I'll just say I would expect nothing less really from Heather and Chris in terms of the response. And I think that sort of the detail of the response gives us a much more of a sort of qualitative feel to the approach that you're taking, and assurance, of course, that you're continuing to focus on this area to get experience heard. So thank you very much.
Thank you. And we can do more, Mark. I think that's the thing I would like to say, though. Yeah.
Okay, thank you. Lee, please.
Hi, thank you. Lee Salisbury, I'm a GP on governing body. Thanks, as ever, Heather and Chris, for all that you're doing. I know that this is just the sort of tip of the iceberg of the work that's gone on behind this, and just the sort of sense of endurance that's needed to see this through. It's really, really tough. And so we really thank you for what you're doing. I've just got 2 questions. One is easier than the other, I think. Historically, we've just always been delighted in Sheffield at the work that's been done to reduce out of city placements. So I was a bit saddened to hear the plan to commission more beds out of city. And I just wondered what the long-term plan was for that. Is that just a temporary measure, and with the view to actually in the long term getting back to no out of city placements? That would be brilliant. And then the second one is just that figure of 50% vacancies. And so really trying to understand what the state of play is within the Care Trust, and I think within the mental health part of SCH as well, because to bring about the changes that we're talking about, it really is that sort of long haul with a definite sort of plan and commitment. It takes masses of energy, innovation, and if you're working with 50% vacancies, lots of temporary staff, are the changes that would, I suppose this isn't a fair question, but as a governing body, we sort of are looking for assurance that are the changes that we're talking about actually doable in the current time? Because I'm thinking about the waiting lists, they're likely to be increasing just because of increased demand. But if you've got decreasing capacity, where is that taking us over the sort of short to medium term?
Yeah, thanks, Lee, for that question, because both of them are really absolutely at the heart of it, which is why I pulled them out as themes. So workforce is a terrible challenge at the moment. The 50% is across certain teams in terms of vacancies, but I think some of the reasons behind that are a national shortage for these specialties anyway. Secondly, having a trust rated inadequate, it's not going to be an easy time to attract people. I think the complexity of demand and the complexity of patient presentation, I'm sure GP colleagues are feeling this in their practices too, means that people working in crisis really do get burnt out. Mental health workers retire at 55, so the workforce is constantly kind of building up the expertise and then shipping out, because that's when they're allowed to leave at 55. And as I said, some of those other provider behaviours where offering golden handshakes of astonishing amounts of money are going to continue to lead us to struggle. So I've pulled it out as a thing because I think it's a system theme. There is work within ICS on workforce development. I think for me, the key is how we build in voluntary sectors into some of the pathways. And I think some of the work that we've done through Sheffield Psychology Board is really helping us to develop some of those potential relationships whereby providers themselves, we're trying to put them into a position, in fact, contractually, we've written to them, to the Care Trust, to say, we'll offer you some money, but you tell us how you will deliver this in partnership with the voluntary sector. Because in terms of prevention, early intervention, they play a role. Through the crisis pathway, in the time of crisis, they can play a role. The crisis buddies that Chris has alluded to earlier in development. So they are experts by experience working with the voluntary sector providers. So, and then post-diagnostic, discharge, etc. So, for example, with SANS, the autism service, we've said to them again, tell us what the voluntary sector can do, particularly in that space, pre and post-diagnosis. So I think some of the answers is for our providers to think a little bit themselves more creatively, that there are other experts in the city apart from themselves. And certainly I met with one of our VCF providers last week, and even though I know them really well, I've not met them for a little while, and I was fairly astonished at just when they would give me the profile of some of the people they were working with, that they were really taking on some very complex people and working well with them. And I think we need to pay more attention to the VCF sector in terms of what it can offer. Answering the thing about the outer city placements, you're absolutely right. We're really disappointed around that for mental health services because Sheffield has led the way. The specific reasons are related to temporary closure of wards for refurbishment and move away from dormitories, and for gender safety, and to do work on ligature risks. Danny, I don't know whether you want to add anything to that from a quality perspective, because you've been involved as well in the recent procurement, haven't you, for replacement beds temporarily?
Yeah, I think so a lot of it is around the dormitory work, because they're having to decant wards and obviously can't do the work while the patients are on the road, so they have had to close some of the units. The reason they have commissioned or looking to procure out of city beds is because currently they spot purchase. There's a lack of continuity and oversight of a number of providers providing that care for out of city. So by procuring an individual provider, they can get some continuity and hold them to account under a contract. I've recently been involved in the procurement for, which is ongoing at the minute, so I can't go into too much detail, a couple of providers that could offer that support under a clear specification that the CCG jointly written with the Care Trust. So we are assured around that, and it allows us to sort of hold that provider to account from a quality perspective.
Okay, thank you. I'm just noting we said about 7, 8, 9, 10 minutes of questions, and we're probably going over that, and we've got another 6 comments to come in, so I'm not going to take any more hands up from this point onwards. And if it's okay, Heather and Chris, I'll probably take 2 or 3 people together, and if we can respond to them as a group, that will probably be quite helpful. So Judy and then Amir, please.
Hi, thanks. There's a few of my points that have been already picked up and responded to, so that's really helpful. Thanks so much to both of you for bringing this. It is really helpful, and it's good to see that there's lots of work happening. But I've, as others have said, not missed. Sorry, I'm Judy Thorley, lay member, Chair Quality Committee. I've not missed the point that you have rightly emphasised, that this is about the system. And one of the points that you made, Heather, was about relationships, and that they have been and are to some degree still strained with some difficulties. So I'm just wondering what you may have for me as a lay member who chairs the Quality Committee. Is there something more that I can do? So one of the things that I've written down for myself is we undertake deep dives as part of our Quality Committee and the way that we work. And I'm thinking that I will ensure that we ask a question as part of that around reasonable adjustments and how, you know, all of our providers work. But is there something that you would ask me, you know, and the committee to do?
Okay, and then if we could take our next question from Amir, please.
Hi, once again, Heather and Christopher, thank you for all this work. Just the enormity and complexity is mind-boggling. For me, really, this is as much a question as a bit of a reflection, and I'll try to be very brief. One of the frustrations in primary care, certainly, and being front cold face working, is it seems difficult to move around the mental health care system. Now, some years ago, we had this phrase of parity of esteem. And if we compare it with the physical medicine, for want of a better words, it's a lot easier to move around that system than it is in mental health. And I just wonder whether, having taken on this huge amount of work and looking at it system-wise, whether this would be an opportunity to run a thread through where people can go up and down without actually having to come laterally, as often happens, leading to both delays and frustrations. Thank you.
Thank you.
Thank you. Heather, do you want to come back on those 2 points?
Okay. Thank you for the offer, Judy. I'll give that a bit of reflection and talk to the team about that. I think your offer around reasonable adjustments is always welcome. It's something I like to bang on about in my entire life, really. I think that is one of the keys, and I've just come out of a meeting discussing that around schools and how schools adjust to people with autism, for example. So with colleague Kate Gleave. So we'll give that a little bit of thought. I think the relationships bit is, it's both at a sort of micro level, consultant to consultant, and then team level, and it fluctuates. And then the teams are bigger because we're talking about local authority, different teams as well. So I think it's a fluctuating position. One of the things that we've talked about to the children's and care trustees about whether they could go for joint appointments, some joint training and some development work together. So that is part of the plan that we're trying to implement. Amir, your question about parity of esteem, and of course, I have to try and put my Steve Thomas head on and say, of course, parity of esteem is underlying this because many years of that kind of disparity of esteem works through. But I do think that there is something about efficiency, and I do think the primary care mental health initiative and early implementer is teaching us something about working differently that the care trust themselves will learn about. I think we also need to look about how organisations are skilled. Just reflecting back on the Autism Partnership Board reflections was that if you have autism and mental health problems, when you come into the mental health service, are they as able to work with you and understand your autism as they perhaps could be? So I think that sort of, there's a number of things that underpin what you're talking about, and the frustrations in primary care, I can imagine, are immense when you make a referral and bounce backwards and forwards. One of the things that in the crisis space, they've had people managed in different areas by different managers in the Care Trust. They're bringing that all together. I think that will help. They'll be sited together on one site at Longley. That will help. But I think it is all that sort of building on the relationships and just really having a look at SHSC and shaking some of the methods of delivery.
Okay, thank you. So again, recognising the time, if we can keep questions fairly brief if possible. Zach and then Jackie, please. And again, if it's okay, Heather, we'll take questions as groups.
Yeah.
We've got you on mute, Zach.
Sorry, Terry.
Thank you.
Yeah, it was, first question was around the workforce and just a concern that seeing a lot of mental health issues in general practice. I think it's a sort of ticking time bomb of COVID. And it's just really concerned about the ability to attract workforce and keep them. And it's just trying to raise the profile of that, particularly within the ACP, to make sure it's on the radar, and perhaps we can try and look into why we're struggling and whether there's any innovative ways of attracting people, some of which you discussed earlier. The other bit is been involved in a couple of sort of case reviews, and the NHS England commissioned beds, is it tier 4, seem to be a significant issue around capacity. So I guess it's what assurance that we're getting from NHS England that gap will be plugged, because it does seem to be a recurring theme that we're getting there. So it might be useful to try and get an update on where we are with creating extra capacity within that bed group.
Let's take those two.
Okay, and then Jackie, please.
I'm sorry, yeah.
Sorry, mine's more a comment, so you probably don't need to respond to that. Just really highlighting that we do have a conundrum. So I think part of the workforce challenge is the increased investment we've put into mental health over the last number of years. And that has obviously been a really important thing, but the ability to fill the additional posts that we've funded has been a challenge, and actually some of those posts have been more attractive to people that are struggling in more acute areas. So we've actually contributed to some of the problem that we're now facing through that. And I think the areas that Heather's highlighted about looking at alternative workforce and how we address things differently has been key in terms of doing that. But I think we need to recognise as a governing body, part of this has been what we've created through quite rightly wanting to target investment into mental health services.
Okay, thank you. So Heather, do you want to quickly take two final points, and then we'll wrap it all up together? So Trish and then Chris Neal, please.
Thank you. My name's Trish Edney and I'm a representative for Healthwatch. I've got a very brief factual question and then a comment. The question is the Psychiatric Decisions Unit. Is that a new provision of new beds, and how long does a patient end up staying there?
Yeah, sure.
My comment is, as an outsider looking at a CCG coping with a trust that is in trouble, you have done what you really love to do and are super at doing, rolling up your sleeves and getting down to it and solving the problem. In your presentation, where was the provider? There was no mention of what the provider is doing and how you are actually prodding them and helping them. It sounds as though the CCG is having to solve all the problem.
Thank you, Trish. I think there was a slide that it said what are some of the providers doing and some of the improvements that they've made. But this very much is a system piece of work, and Chris is actually appointed on behalf of the system, not just the CCG. So it is definitely work that we're doing in partnership with our Children's Hospital colleagues who have been fantastically engaged, and the teaching hospital and SHSC and the voluntary sector. So it is definitely multi-agency. The PDU, very briefly, just to answer your factual question, is an assessment service. It's not an inpatient unit, it's reclining seats. It's a maximum stay of 72 hours, but we encourage it to be less. It's somewhere where somebody can go to de-escalate and await further assessment and observation. And it's to try to take people away from A&E to do that kind of waiting and de-escalation space. So we're wanting to look at that in detail in the programme, just to see if it is doing what we want it to do and providing the right function too. So that is in scope for us to look at.
Okay, and then Chris, please, finally.
Chris Neal, lay member. It's really to do with the voluntary sector. I know you said you've got stronger links with them as providers and looking at that, but we had a presentation about work of ShipShape in relation to COVID and vaccination. I think there's still great potential to do much more because they're community focused and much of their work is about mental health and well-being. Some fantastic training as well for community members. Mark mentioned the champions training, and a lot of people that have got more low-level mental health problems that have been engaged in that and then got jobs, training, or volunteered. But also over COVID, organisations like Manor and Castle Development Trust had, I don't know if that's who you were referring to earlier, Heather, have referrals from a lot of GPs. They didn't know about these people before, extremely isolated, to the point of, maybe not being able to survive through COVID without that link, and, sometimes suicide risk, but high level. So I think there's great potential to do more systematically and formally. And some of their funding for doing some of this training they do is not there really. So that was the point I wanted to make and encourage you to look at it.
Yeah, thank you. So if I can just respond to that, constantly when I talk to my VCF colleagues, I can see that they can do more. It's trying to strip money out of other areas in order to get them to do that, and it's almost, how do we sort of stop a tanker moving forwards and consuming resource and get it out there? But we are committed to that, and through the work of the primary care mental health work that James Sutherland's been leading on in our team, we are getting more voluntary sector provision in the front line, and the work that Chris is doing around crisis buddies. But I do feel we need to take a real fundamental look at that, and that's something that we're committed to. So just to come back to your point as well, Zach, in terms of the workforce and the ticking time bomb, EMG did kindly agree to some funding in the voluntary sector to give them some ability to sustain themselves through this period, because they were pointing out that often NHS organisations could have workplace wellbeing support within their own organisations, but the voluntary sector were just out there on their own. So we have actually invested in something called Thinking Environment and Thinking Space for them to do some work, and they're actually training together within the voluntary sector alongside some of the NHS colleagues as well to offer that support to each other to help to sustain them.
Okay, thank you, Heather. And then just final bit, Chris has made two good points in the chat there. Just to make sure that we get those on the public record, I'll just bring Chris back in to verbalise those points for us.
Thanks, Terry. Yeah, in response to the workforce questions, which obviously really key, it is something that will be on the agenda of future design group meetings. So I've been linking in on a regional basis around this as well, and trying to understand how we can be more creative and innovative in our approaches to workforce development, and potentially looking at things that we can offer to potential staff that others can't, whatever that is. And also, again, on the workforce, just building on what Heather said earlier, I think we need to look at the voluntary sector, and I really don't think we should underestimate how impactful alternative crisis provisions, such as a crisis cafe and that mental health cafe network and the peer support will be. And I think if we get that right, we will see a reduction in pressure on acute services and ED, and that obviously is the reason for doing it. And again, just the final point, I think sometimes we get a bit hung up on trying to pigeonhole people. If someone needs support, they need support from somewhere. And if that stops them going into a crisis, then it's better for everybody, isn't it? So I think we just need to make sure that we consider those barriers and referral routes, and then obviously give people the support they need and make sure that they've got access to that support.
Okay, thank you. So Chris, Heather, thank you very much for coming and giving really thorough oversight of what is actually quite a small part of your portfolio's work. Keep coming back and keep updating us, because it was really insightful, really, really helpful, kind of to see where the plans are going and actually to see them going forwards in a different way. So thank you very much to both of you, and I'm sure we'll see you again in due course.
Thank you for your time and questions. Thank you.
Take care. Thank you.
Bye-bye.
Okay, I'll move us now to item number 11, paper F in the papers for consideration. Just to note, we're being asked to consider the policy rather than approve the policy, which will be approved by the joint committee of CCGs as per our delegation agreement. So I'm going to hand over to Sandy, please, to introduce this item.
Thank you, Chair. So this policy has been previously to governing body and previously outlined the first phase of the evidence-based interventions programme. Today I'm bringing the second phase, and within this, the second version, and part of it, it's included a list of 31 tests, interventions and procedures where the evidence about their effectiveness or appropriateness has changed. And I'll just read this next bit. It was led by the Academy of Medical Royal Colleges in association with the Patients Association. And this second list has been signed off by the Expert Advisory Committee, which is an independent group including clinicians, commissioners, patients and academics, to really make that point of it has been thoroughly evidence-based and gone through the necessary processes in order to get to this point in embedded within this policy. So this policy, the Commissionings for Outcome, is being implemented across the whole of South Yorkshire and Bassetlaw. And as Terry said, the final endorsement will be made at the Joint Committee of CCG. So this same policy is going to the other other four places, governing bodies as well. In Sheffield, we have undertaken a full engagement exercise. Zach, our medical director, and our clinical directors have reviewed the policy. We've used and gone through our Sheffield Clinical Reference Group, which contains primary and secondary care clinicians, and asked for their views and comments on the policy itself. And going through that route, a number of comments were returned, with the majority of support for consistency, as well as a need to embed evidence-based practice within these particular interventions. The LMC have also been involved and posed questions around the monitoring and implementation of the policy. And this is something that we are working across South Yorkshire and Bassetlaw on. And bearing in mind that we want to engage with clinicians across the ICS on such things such as thresholds and how we monitor the uptake of the policy itself. I'll lastly say that our IFR team have heavily been involved in this work, and I would like to acknowledge Dr. Claire Freeman for her support with this policy and ongoing work in terms of implementation. So they're the key points I wanted to raise from the paper itself, and as said, it's for governing body to consider the policy. I am happy to take any questions. I wasn't going to present today. I was asked a clinician to present. So if I'm unable to answer them, then I will get back to you, but happy to take questions if I can.
Thank you, Sandy. So yes, if we can open up to questions and comments and general feedback to help the joint committee in getting this one signed off towards the end. And I think it would be quite helpful to hear from some of our clinicians, just hearing about the clinical engagement. I might also ask Zach if you can just give a little bit of an oversight of that clinical engagement process, and hopefully that will provide some assurance to governing body. So Lee first, please.
Thanks for this, Sandy. And I did see this through the clinical reference group. Absolutely support evidence-based medicine is the bottom line. I just really wanted assurance, as you might expect, about the part where it was talking about how other members of SYB have, it actually states in the paper that I was reading, that they don't routinely commission surgery for people who smoke or who've got a BMI of greater than 30. And if that's what it says, there's a little bit underneath that about, well, actually we refer them on, Barnsley's got Get Fit first and Rotherham's got Fitter Better sooner. So presumably they do commission surgery for people who smoke and are overweight. I'm really pleased that it looks like in Sheffield we've kept a different policy to that, and I just really wanted assurance that that was going to stay. Because particularly when looking at evidence for varicose vein surgery and for particularly arthroplasty, I mean, I've checked the evidence again today in the CKS NICE guidance, and there's no evidence, there's no mention of BMI, particularly as regards to varicose vein surgery. And these people are already at risk of complications. That's why they're being referred. They've ticked the boxes for referral. And so delaying surgery is just going to increase the risk of complications. And in the actual CKS guidance for orthopaedics referrals, it says consider referral to an orthopaedic surgeon irrespective of the person's age, BMI or comorbidities before the person has severe functional limitation and or pain and or significant impact on a person's life. So I am concerned that other cities and towns in our area are taking BMI and smoking as a reason to delay people's surgeries, and it will increase health inequalities, because we know, and all the evidence will tell us, that you're more likely to smoke and you're more likely to be overweight if you're in an area of deprivation. So I suppose I just needed to get that in, but also was really seeking assurance that Sheffield is going to stick to the policy that we have at the moment, while supporting all the other evidence-based stuff that does seem to be genuinely evidence-based, rather than rationing surgery, which I think that's what this is. And I think there's an ethical problem in withholding treatment, which is indicated in order to persuade people to change their behaviour. I think you can refer for treatment and advise change in behaviour, but withholding treatment in order to make people change, I think there's an ethical issue. And I would be really, really interested in the results from the Get Fit First and the Fitter Better sooner as well. And it'd be lovely if we could actually see that. That'd be really helpful. I'll stop.
Okay, thanks, Lee. I'm not sure, Sandy, whether you're going to be able to answer the clinical component of that, but I'll step in and save you there. We'll make sure that that's handed back through to Joint Committee, Lee, as we're making that decision. Yeah, and absolutely hear your point there about we shouldn't be rationing surgery necessarily on lifestyle choice or medical conditions or other things that are contributing to that inequality. But I guess the view from a surgeon or an anaesthetist may be that you have a worse post-surgical outcome, and it's a very difficult balance. So do you take somebody to theatre that is physiologically optimized versus somebody who's not, and it's a real ethical tightrope, isn't it?
It is. I think that would need to be discussed in depth, because we haven't got time to go into that now, but I think that it is an ethical dilemma, and I think this actually isn't about that. I think it's about trying to change people's behaviour.
Okay, next comment then from Amir, please.
Hi, Sandy. I'm not sure whether you'll be able to answer this or not, but I'd like it to be kind of passed on. Just one of the things with the evidence-based medicine is it seems so black and white from the outside, but from where, oh, I'm sorry, I'm Amir Afzal, GP. I don't think I introduced myself, one of the GP governing body locality reps. But one of the problems from where I, another GP, stand is that we don't actually deal with populations, we deal with individuals. So we get caught up with this IFR, the exceptions to this thing. And one of the frustrations for me has always been that for some reason, the IFR panel, when it refuses a request, refuses to write to the patient or CC the patient as they answer us back. And I was just wondering whether, given that our now secondary care colleagues and everybody, most of the people now CC people into their medical care, why should IFR be any different? Because that can then occasionally lead to problems where I actually don't agree with the IFR and I have great difficulty explaining to my patients why it's being refused. And when I've tried to get hold of the panel to say, look, can you give this patient an explanation for why this has been refused, it's not been forthcoming. So I just wonder whether we could have a relook at that policy, unless I'm mistaken and they've now started doing that, because it's been some time since I've done an IFR. Thank you.
Okay.
Thank you,
Thanks, Amir. I'm just wondering whether, because the IFR policy is quite broad ranging, whether we bring that back as a more detailed discussion at a later point, Amir, but I'll let Sandy respond.
I was actually going to ask if Danny wouldn't mind coming in on this point, because it does come under her area of expertise.
It is a national policy. And it is a sort of an NHS England policy, but I completely appreciate where you're coming from, Amir. So I'll take that back, and if you can, I'll follow it up at the next one of the next governing body meetings in terms of what we can do in order to support that.
Thank you, Danny.
Okay.
So I was trying to come in to help out, but I was on mute. So we could have that discussion with Claire, because I think that would be useful. I'm not sure there's any reason why it couldn't be copied to the patient, but it's just something that we've never really thought about. And just a reassurance around the BMI and the smoking. I've been given the assurance that Sheffield will be treated differently, because as a governing body, we couldn't support that in the past, and I still can't support it. So I think the intention, or I've been assured that the intention of the paper is that there will still be that differential with Sheffield that will apply, because our Director of Public Health has got a very strong view in that as well. So I think if there's any change to that, it would have to come back through governing body for us to approve that change.
Thanks, Zach. And I think it is noted in the cover paper just specifically that there is still local interpretation of this SYB policy, hence why there may be some differences coming out there. So hopefully that gives the assurance that you need, Lee, just around some of those specifics there. Okay, Lucy and then Marion together, please.
Thank you, and thanks, Sandy. It's good to see all the clinical engagement. Well, firstly, I can't, because the paper's so detailed and there's so many interventions, it's quite hard to get a feel for what's going to change. But I just wondered what local involvement have been with Sheffield people. And also, is it a change in offer? Because looking at some of them, like the grommets and the tonsillectomies, is the guidance changing? So actually, based on a few years ago, because if it is, then that's a change in offer. And I think we have a moral and a legal duty to involve Sheffield people before the policy is approved. And at least as a minimum, do like a Sheffield Equality Impact Assessment. And that will build in some of the deprivation and health inequalities that, that Lee touched upon.
Okay, Marion, please.
Thank you. Can you hear me? Yeah?
Yeah.
Yes. So things change with time, and on that list it says they don't any longer allow hysterectomies. And I think that's something we have to take note of, because when I first started, people went in for the major as a part of middle years in a family. So things do change, and health attitudes change. And I think now everybody is into the groove of patient-centered care. So this decision can only be made for an individual with their specialist and their GP in consultation. So if somebody has got a very high surgical risk and the anaesthetist says to them, you might die with this, then that's something that has to be wound into that decision between those people, and it's up to them. So we can national guidance and all those things, but this boils down to patient safety, individual choice, and patient-centred care. You can't necessarily make a blanket for everybody. If they're not suitable for surgery, they can go to the pain service, and it may be a second best, but it might be a lifesaver. So I think we have to go into it with open eyes. And this is a very, very thorny piece of work. And if you remember, it nearly split us all asunder 2 or 3 years ago. You know, it really, really did. Anyway, we'll do that. But at the end of the day, the public health people prevailed, and Greg and Juzak, common sense prevailed, and I think the same will happen again. And thanks for that.
Okay. And if I take Judy and then Mark, please, and then Sandy, if there's any specifics that you can come back on, we'll do that.
It was just in relation to the fact that the IFR panel don't write to the individual patients. I seem to remember back in Cheshire, we had this issue, and there was I don't know if it sounds as though this is a similar arrangement whereby a group of people are commissioned to do this on our behalf in terms of IFR. So my point being, we had developed a standard letter that we asked the panel to use to go back to patient population. So it may be worth contacting Cheshire.
Okay, thank you. Mark, please.
Yeah, just my question was very similar to Lucy's, which is, are we assured that the National Quality Impact Assessment is fit for purpose? And secondly, should we be conducting a local one if there are substantial changes that might arise from this that involves the public?
Okay, so Sandy, there's probably a myriad of questions there to come back on.
But I think Lucy's and Mark's point is very valid. I mean, obviously, on a national basis, patients were involved in that, but I'm very much happy to work with Lucy and her advice on what we could do locally in Sheffield. The policy is obviously evidence-based, affects more secondary care than it does primary care. But obviously, you know, I will absolutely take Lucy's advice in terms of engagement and follow up with the Sheffield population. Absolutely. Like I said, we've done clinical engagement. I'm more than happy to then take that next step. And as you rightly said, Terry, in terms of there is local variation across South Yorkshire and Bassetlaw, and that is being managed at that ICS level within the Joint Committee. But the comments that Lee you've made, especially, I'm happy to share with my fellow directors of commissioning to make sure that it is brought up within their discussions around the policy. Zach, did you want to come in and just on the final point from a clinical perspective on this policy for any of those points?
Yeah, I think just to say that, I mean, Claire Freeman works closely with us. So I think from an evidence base, I would be happy at her interpretation that it does follow the evidence quite closely. I think all the other points are valid. I do think it's really important that the Sheffield view, particularly around the BMI and the smoking, I think we've got to have that discretion. But again, I've been assured that that is the case. So just probably worth making sure that if we do get any change like that, it would have to come back through the governing body. So maybe specifically saying that we approve it, but on the basis that if any further changes happen, we would want to be involved and have a further clinical discussion or wider discussion within governing body.
Okay, thank you. So we will take all of those pieces of comments, feedback and questions back to Joint Committee, and hopefully we'll be able to bring back the response to our governing body in due course. Okay, thank you all. So now move us on to item 13 on the agenda, paper H in your noting pack, which is a few items coming together. So it's a collection of items under the governance report. So over to Kath, please. Could you unmute for us, Kath?
Thank you. Sorry about that. Thanks, Chair. So we've just got a few items here. This will
Sorry, Terry. Have we missed out the best person?
Indeed, we have. Apologies for that.
Oh, I wasn't expecting it so quickly. Okay.
It is the timing. So apologies for that. We shall go back because I'm sure Jenny wishes to escape at some point. Thank you for pointing that one out, Jackie. So we're now item number 12, in fact, item G on the paper pack. And this is an annual update on the Better Care Fund. So over to Jenny Milner, please.
Hi, I'm Jenny Milner, the Deputy Director for Planning and Joint Commissioning, and I'll keep this brief because I know you're running a little bit late. You will have had copies. Can you see the presentation okay? Yeah? Yeah.
Yes, thank you.
Yeah, so you all will have had copies of the annual report. So just a brief summary, majority will be familiar, but I'm conscious it is a public meeting. The Better Care Fund is where it's a national programme that local authorities and CCGs have where we pool our budgets together to deliver the services across Sheffield and nationally, ours is for Sheffield. Ours goes beyond the minimum contribution and covers much wider areas that I'll give a few more details on as we go through this. So our Better Care Fund is supported by a narrative plan that's available on the Health and Wellbeing Board website and the CCG website. Our ambitions remain the same: a seamless service, integrated care, making sure that we prevent duplication across health and social care and in our services that exist, and that we're working together to redesign the health and social care system so that people become less reliant on hospital care and are able to access more care out of hospital, closer to their own homes and in their own communities. And that overall, our constant struggle is to do that with a reducing budget as demand either increases or budget reduces. So we've got the narrative plan that we've had from 2017-2019. This year we operated on an interim plan because we weren't sure what the longer term guidance would be. As a result of COVID, we've still not got kind of a 5-year plan for Better Care Fund. It is included in the ICS legislation, but currently we're operating year to year. So what we've developed locally is the joint commissioning plan that I will cover in a bit more detail. So we've established a joint commissioning committee, which is governing body members and cabinet members that come together to support delivery of our Better Care Fund. And throughout COVID, that infrastructure has enabled us to bring significant amounts of investment into the city because we've demonstrated that we've got a robust governance process in place across health and social care to ensure that the funds come in, go right out to the front line and that we can be held accountable for them. So during last year, you'll note as I go through the budgets, we have covered a lot of the COVID money as well. Just a brief update on some of the things we did. We've continued to work with our voluntary sector really quite strongly, and we've embraced them during COVID to ensure they support much of our services, particularly around discharge and keeping people at home from hospital. One of the things I'll cover in more detail, but we've sustained our delayed transfers of care figures. We've achieved our targets this year, which is a real, given the emphasis on ensuring hospitals have capacity to cope with people during COVID, and given the significant pressures in the community of staff that were isolating and the gaps in provision, we have still been able to, during 2020-21, get people out of hospital in a timely manner. And we've then kept those people at home. So one of the measures is how many of them are still at home 91 days following that discharge, and we've achieved that target as well. And kept on track with that, just slightly in Q4 going off track, but that's a result of the high levels of numbers coming out and the high numbers of staff isolating. We've improved our community equipment service. You've heard in depth about some of the work that mental health has been doing throughout, so I won't cover that again. But we are working really collectively on the assessment process for people across health and social care so that people don't have to tell their story twice. One of the things that Chris said about people in crisis not wanting to repeat, that runs throughout everything. No one wants to tell their story several times to several different people when they're accessing services. So through digital solutions and much of the work we're doing, we're trying to improve that process for everyone and continuing to improve the urgent and emergency responses. So our plan for 2020-21, it was an unusual year. The funding changed into the NHS as a result of the COVID pandemic. Performance targets were actually stood down from national reporting, but locally we kept a track of them. So we were able to see how we were doing, because we still feel these are a really key measure of how well the system's performing and we're working together. We used our Section 75, the legal mechanism to manage the money across the system, and we continue to contribute more into local authority, community care and social care from the health than the minimum contribution. The Better Care Fund planning submission, it was approved by Terry this year as it was submitted, and demonstrated that we delivered within the planned budget as we expected to. It was a light touch regime given the step down of the performance targets, but we still demonstrated financially what we'd done and updated on the plan. And as it states there, Terry approved that on behalf of the governing body and the Health and Wellbeing Board due to the timing of it with the local elections and George being newly appointed, or not appointed at that point. So the 2020 outturn position, we did, as you will see, actually spend more than our budget, but that was a result of the additional funds that came in COVID grants to support independent sector providers, infection control and a variety of other things. So we weren't over the budget as planned. We delivered within the grants and all of the money that we had. There's a couple in the areas that did deliver under budget. One of them is people keeping well area, and that was due to the pressures of recruitment and the challenges just on the system this year. The other area is the disabled facility grant, and that was under budget as a result of being unable to gain access to properties as a result of COVID and the way that things operated last year. But we are doing a piece of work to look at some of that underspend to do a project to make sure we can roll some of that out in this year and future years. So our planning for next year, we're only getting NHS funding in 6 months instalments. So we're waiting for the second half of the year to be confirmed. We haven't yet got the planning guidance until July, but we don't expect it to change significantly from the work that we are doing. So we've got plans in place across each of the programmes that this year is being aligned to the Joint Commissioning Plan and Joint Commissioning intentions, and work is ongoing to map those budgets across that way as well, so we can track that in future and our future plans. We will continue from the NHS perspective to put in the minimum contribution with the uplift and the additional funds of previously, so that our plans can continue. And we expect that to continue throughout 22-23 at the minute, given the current situation. From a performance perspective, as you can see, we achieved each of the targets for readmission of people discharged from hospital, not going back into hospital within 90 days. So we were re-abling people as expected. We were on track with the delayed transfers of care, which you'll remember is a real stretch target for us. When I first came, we had 167 people each month delayed, and we reduced that to 45, and we've sustained that during one of the most difficult years that we've gone through, which is a real credit to everyone working in that space. It is currently, and it's something we'll make governing aware of, just slightly deteriorating that position due to the pressures in the hospital at the moment and the pressures in the independent sector and some of the services. So we have got a recovery plan in place for that, that we tracked through Q1. And the real success is the number of people, given the pressures on residential care and the concerns with COVID, we had a real emphasis last year to not place people in permanent residential care that could be maintained and sustained at home. And you can see from Q4, we exceeded that massively in our achievements. But there is another side to that the financial pressure that's put on our social care is quite significant. So there's a lot of work ongoing to ensure that the services that we put in place and we offer an equitable offer across the city, but also to ensure it's financially sustainable in the longer term. And we need to understand what impact that might have had on the care home market as well, so that we've got a safe and stable market. This again reiterates some of that information. The non-elective admissions, because we were not reporting nationally, we've not actually captured specifically this core set of data. So our data for Better Care Fund relates to over 65s, not surgical admissions, which is a very specific data set to extract from a really big database. So we've at the minute still working on understanding what the plan was for last year and what the outturn was, and we've had to retrospectively go back to try and track that just for our own information. So we'll get that and update the record when it's available to us. The DTOC, we did, I said, achieve the target. The legislation now changed during COVID, so no longer is NHS England measuring delayed transfers of care. They're capturing it by criteria to reside and how many people are still in hospital once they no longer need to be there. So as we go forward into this year, reporting might slightly change on that. But locally in Sheffield, we do still continue and will continue to track the delayed transfers of care as a metric. So we've got a consistent picture until people are more familiar with the new targets so that we can see where we're doing, because I think it's always good to keep that benchmark in place. And that covers the other areas of how well we did managing to get people back home. This year we've got the joint commissioning plan, as Sandy touched upon. We've collectively across the CCG and the local authority identified what our priorities are, and we're working together on those work streams to ensure that we deliver the commissioning intentions to achieve integrated services and that our ambitions in that space. We'll continue to respond to the COVID pandemic. Many areas and much of the public think it's over, and it's long from over in social care and primary care. We're all struggling to deal with that. So we're dealing with the COVID pandemic still. We're dealing with the impact of long COVID on many of the people that access social care. That's going to have significant pressures for them. People are being less mobile during the pandemic, as well as potentially having had COVID and recovering from it. And that's impacting that the acuity of people coming through now is much higher than previously. We continue to reduce the health inequalities. We recognise that the pressures that's happened during COVID will widen that gap, and we need to ensure that we slow that and bring it back as much as possible. Make sure that services are as accessible as possible. And the other areas in there, services, as always, will be personalised to the individual and their needs. We've done a lot of work bringing together health and social care. We've now got, as well as the Joint Commissioning Committee, we've got a Joint Commissioning Development Group where heads of service and deputies are coming together to share space to think about how we develop and deliver services collectively. We're also got a common understanding with operational staff, so we're feeding back into that what impact this is having on the front line. And as Sandy said, this year we're developing the outcomes framework, which will really be where we get the benchmark of data, the triangulation with working with the voluntary sector organisations and listening to the public to understand the so what. So we've done this, what impact does it have, and are we making a difference to people's lives, and are we doing the right thing as we go along? So we're working in partnership with our health and social care colleagues, with our statutory organisations, voluntary sector ones, with GPs in the hospital, constantly monitoring services. Quality of provision, we've got a quality governance group that's working across health and social care to look at the standards of care, not just in statutory but in descendant sector services. And then working in partnership with Sheffield People as well. So a big theme of this engagement, part of the work with the adult social care strategy is engaging with providers and service users to understand how best we find out what they want out of adult social care and health services. And we'll work with them to make sure the services that we do are meeting their needs, and that any changes that we've got have been informed by their views as well, and they're a part of it and they feel a part of it. And that's the end of my update.
Thank you very much, Jenny, for condensing what's actually a really complex piece of work into such a small number of slides and whizzing through that. So I note that we're being invited to do a number of things here, Jenny, to note the update on the programme, note the budget from 2020 and 2021, to note some of the progress on the development of the joint commissioning plan, which actually we have discussed some of those commissioning intentions previously, to note that the guidance from NHSE has been delayed, and to note some of the proposed budgets and priorities for the next financial year, recognising the challenges of only really knowing about half of the budget at this stage. So I'll open up to questions and comments, please. I think you've bamboozled everyone, Jenny. I think there's a lot of information there. So I'm just wondering, obviously, I think everybody will have noted the position from last year, and Sandy has received quite a bit of feedback on the commissioning intentions and also the commissioning outcomes framework. But just if any members of governing body have got any comments they want to make about the proposed priorities for the next year. Nope, nobody. So what we'll do, I know you're in close contact with Sandy. Sandy can feed back the responses we've had to the operational plan earlier, and to build in the previous sets of discussions we've had and engagement we've had on that. But it just leaves me to say thank you, Jenny, for coming and presenting that to us. And I think we might have you back a little bit later on in the year, just because governing body have requested a session to go through some of the more specific nuances of the Better Care Fund itself. So thank you. Okay, item number 13. So back over to Kath for the governance report.
Thank you, Terry. So this should be a relatively quick item. There were a few governance related issues that we thought would be good to bring, so we've put them all in one report to keep it nice and tidy. So I'll just quickly run through them. Back in January, governing body approved some changes to the constitution, and so that has since been through all the processes it needs to go through. It's been approved by NHS England and it's been published on our website as is required for us to do. So I just wanted to thank Sue Lang, who's recently retired as the governance lead, and also Carol Henderson, who is now our governance lead, for the significant amount of work that they put into doing this. Second item is in the last governing body. The members approved for the chair and accountable officer to sign the CCG's letter of management representation to KPMG and our external auditors on behalf of governing body. So this has taken place and it was submitted within the deadline. And then Terry has actually updated on the third one I've got on my list, which is around the annual assessment process and the meeting that took place yesterday with NHS England, and said that this will come back to governing body when we've had the narrative statement from NHS England. So that's the third one. And then the final one is linked to the governing body assurance framework review timetable. And the process we have is that the Audit and Integrated Governance Committee has responsibility for signing that off and looking at the reviews and the risks prior to submission to governing body. Due to the timetable of when we have the meetings for the first review period, we're going to circulate the review via email to the committee before it comes to governing bodies, so that we can make sure we have a sensible timescale for review. And we've shared the timetable that we're proposing to include with the reviews. So we didn't really think it was big enough for an approval, but just to sort of consider and accept that timetable would be helpful, and the rest of the noting. That's me.
Okay, thank you. So any questions or comments on the governance report? Nope. Thank you, Kath, for that brief summary. Now on to item number 14, which is the month 2 finance report, paper I in the noting packs. Over to Jackie Mills, please.
Thank you, Terry. So I don't think I introduced myself earlier either. So I'm Jackie Mills, I'm Director of Finance. I'll just pull out some key points from the report, recognising the time. Governing body members will recall that whilst we're only into the beginning of July, we've already approved 2 financial plans for the current financial year. So the first was approved on the 4th of March, and that was for the full financial year, but that was before we had confirmation of the financial allocations for 2021 and 22 and the financial arrangements. So subsequent to that, on the in the early May governing body, we approved a revised financial plan, and that was just for the first 6 months of the financial year, i.e. from April to September 2021. And that was following confirmation of the planning requirements and the financial framework from NHS England. So this report is actually the first opportunity that the governing bodies had to receive an update on the financial position for the first half of the year, and noting that obviously, as we just at the beginning of July. That's halfway through the time period covered by the revised financial plan. The report sets out the current position at the end of May. It gives a forecast spend to the end of September. But members will be aware from past experience, there's often limited amounts of information at this time of year on which to base financial predictions. And particularly this year, there are a range of assumptions about additional income because of some of the complexity about income flows. So there is some complexity about some of the income we're assuming, and that will need to be firmed up, particularly around anticipated additional allocations from the hospital discharge programme, which we're currently forecasting will be drawing down around 2.7 million, and the report highlights some risks in terms of that, as well as our share of the elective recovery fund, which at the moment we're forecasting is just short of £1 million. So there is some further work we need to do on clarifying whether they're realistic forecasts for those. So it's for that reason that I've RAG rated the delivery of our break-even duty in the table on page 3 of the report. I've RAG rated that as amber. I've also highlighted a range of risks to delivery of the financial position that I highlighted in section 6 of the report. I do want to draw out though, you might recall that when I presented the revised plan in May, I had quantified a significant level of financial risk and governing body members were supportive of, despite that level of risk, that we would still submit a balanced plan. The revised risk assessment we've done has reduced the level of quantified risk from around 6 million that I reported to you in May to nearer 3 million, a range of plus or minus 3 million. That reduction in risk is partly due to the benefit that I reported to you when we signed off the final audited accounts, whereby the actual spend on prescribing in March was quite a bit lower than we'd allowed for in the accounts. And we actually get that benefit coming through to the current financial year, so that is positive. And the other area is we've revised our estimate regarding our VAT commitments due to some recent clarification on some, I won't go into the technicalities, but a specific VAT treatment that we provided for. So both of those things do give us some benefit, but we are still managing a range of risks that mean at the moment I'm RAG rating delivery of the financial position as amber. The final part of the report I just want to draw your attention to is, as Jenny noted, the arrangements for the second 6 months of the financial year are still to be confirmed. And yet our dilemma is that our statutory duty is to deliver a balanced financial position across the whole year. So it's important that governing body members are cited on that duty, despite the fact that there's a great deal of uncertainty about what the second half of the year will look like. So it's for this reason that I've shown an indicative forecast in this report for the second half of the year. But you might notice that I've greyed out the Appendix B just to indicate that it's very much indicative at this stage because there's lots of information we still need in terms of being able to clarify the arrangements for the second half of the year. And that will require us to refine our forecasts. But it is something that I think is key that I keep you updated on, and I will continue to report as much as we can. And also in the report, I've set out a range of risks to delivery of the position in the second half of the year that are highlighted in section 7 of the report. So I think they were the key things I just wanted to draw to your attention. You know, you'll be aware from previous conversation, it is a very complex and it's a very fluid position, but I think it's important that I give you as much information as we can regarding the level of risk. The final thing just to note, I am expecting that I think there's a national webinar with the National Director of Finance over the next few days, so we may get some more information around the arrangements for the second half of the year. We are not expecting that we'll have a formal meeting in public in August, but I think probably we need to just confirm that at the end, Terry, but I will provide an update via email and on our website just in terms of the ongoing financial position. So I'm happy to take any questions or comments.
Thank you, Jackie. And I suspect having some more detail on it would be very welcome by all CCGs, but we will sit optimistically and hope that we get that information. Any questions or comments? So Anthea, please.
Hello, my name is Anthea Morris and I'm the lay member for Audit and Governance. So Jackie, thank you for producing the report, and I know it's difficult to do that while you've had the month end going as well and producing the detail that's in it. Year end, sorry, not the month end. I sort of wanted to talk more about the uncertainty going forward in months 7 and 12, and I think really there's probably not a lot that can be said, but I just wanted to check, are we doing anything unusual from other CCGs in the patch in terms of our forecasting? I think it's the right thing to do, that we need to do something now. We need to get something on paper. We can't just stop going with the number of governing body meetings that we have between now and the 30th of September. But what pressure can we do, especially with changes at the top, with a new health minister and a new CEO as well? What else do you think we can be doing to help to at least plan for different eventualities, if not mitigate the risk?
I think the issue that's exercising me and probably is more relevant is the ongoing recurrent commitments that we have going into the next financial year. So we've got an unusual situation this year, but as we move back to previous published allocations and different ways of working, what we're building into the system in terms of recurrent commitments is key. So I think the piece of work that I want to do next is not just what the forecast for this financial year, month 12, will look like, but what recurrent commitments might we be building up against our previously published allocations to give governing body an indication of that additional pressure. I think it's difficult to see. I work closely with the CFOs in the other South Yorkshire and Bassett Law CCG, so we do share assumptions, share intelligence, and compare how we're reporting to governing bodies. So there is increasing consistency in terms of that. We all have our own approach, but we are trying to just share information to get that more consistent. It's difficult to see how we influence the national position. It's still subject to discussion between NHS England, Department of Health and Social Care and Treasury. So I think we just need to be ready to respond as and when information comes out, so we can update our forecasts accordingly.
Thank you.
Thanks, Jackie. Any further questions for Jackie at all? No, thank you, Jackie, for the report. Thank you for the way in which you've kind of presented some of those risks to us. I think that's quite helpful for us as a governing body. And I guess the headline for this is there's a lot of uncertainty ahead of us, and we will be charting our way through that, and hopefully we'll find out more in due course. Okay. Item 15, paper pack J. Just want to welcome Sapphire Johnson, the Head of Commissioning for Children, Young People and Maternity, who is joining Kath on this item, which is the month 2 performance and delivery report, with a specific focus on the progress on the SEND programme.
Thank you, Terry. So I'm going to start off by giving a few brief highlights from the report, and then I'll hand over to Sapphire, who will do a deep dive into the special educational needs and disability SEND programme. So start off with, I think it's worth noting the general movement in the right direction in relation to planned services. It's a small move, but since the start of the pandemic, we've generally seen, particularly with the people waiting over 52 weeks for planned appointments or treatments, that it's constantly been a growing picture. And this is the first month we've started to see it's only a small reduction, but going in the right direction. So that's worth noting. Also worth noting is the high volume of patients with breast symptoms that have been referred to STH. And my understanding is that this was primarily driven by a national press story at the end of March. So so that's something that's worth noting, and will probably work itself out, but the impact may remain for a bit longer. At the last public governing body meeting, Greg Fell, the Director of Public Health, shared a graph with us all, which showed the link between COVID cases in care homes and vaccinations. And so we were about to put that into our next report, and we have got an updated version of that in this report. And then we've got an equally striking graph which shows the relationship between total vaccinations and hospital admissions. So they're worth just seeing just what a great impact it is having. I'm not going to say, I'd also got in my notes to say what Sandy and Greg have said around Sheffield being the top of the 8 core cities, but with only so many times to go. So, then the other thing I wanted to do was talk about mandatory training, particularly the data security awareness mandatory training. So thank you to everyone in the governing body and to all the staff that helped us get to, I think we got to 97% nearly in the end, which is absolutely brilliant. And we needed to do that in order to submit the data security toolkit, which is national requirement in order to be able to process data. We submitted that this week in time with the deadlines, so that's worth noting as well. So I think those are the key points. When Sapphire's finished, if there's anything else people want to ask, feel free to do so, but I'll now hand over to Sapphire.
Thank you very much. Good afternoon, everybody. It's very nice to see you all. It's been a little while since we've been to governing body and spoken to you about the SEND programme, so we thought we'd bring you a bit of an update today. You have had a copy of the slides, I believe, in your papers, but I'm just going to share them with you now. Hopefully you should be able to see that. Yeah. Just to give you a very brief update and overview, so for those of you who are not already aware, when the Children and Families Act came in back in 2013, there were a number of requirements placed on CCGs and local authorities to commission services for children and young people with special educational needs and disabilities, or SEND. And because of that legal framework, it means we are subject to inspection jointly by Ofsted and CQC. So the inspections look at how the local area identifies, assesses and meets the needs of children and young people with SEND, and how good we are at improving their outcomes. Since the pandemic has happened, the inspections also take into consideration how effectively we've understood the experience and the needs of children and young people, how we've involved them in making decisions, and how we've worked with them to prioritise and adapt services throughout the pandemic. So we had our formal inspection back in 2018. We were due to be re-inspected back in the autumn of last year, but due to the pandemic, the re-inspection timeframe has been pushed back. We were expecting a re-inspection in the spring, but given the fact that we are now 2 weeks away from the summer holidays, we think it's unlikely we will be inspected this term, and it's now becoming more likely that we'll be re-inspected in the autumn. So just to recap very briefly, on the back of the last inspection in 2018, we were given 7 areas of improvement to work on. They're detailed here. So they were around the strategy, which governing body has had sight of and approved, and that has now got an implementation plan that's being delivered, around the communication with families, the strategic oversight of the CCG, and weaknesses in commissioning arrangements, both of which I'll come on to in a little bit more detail. The quality and timeliness of EHCPs, which is still a challenge. We are still having difficulties with delivering those within the 20-week time frame. Inconsistencies mainly in mainstream schools with how needs are assessed and met, and weaknesses in transition arrangements. So I'm just going to talk about the third area, the CCG oversight, in a little bit more detail. So the areas in green, I'm not going to talk through them all. These are the ones where we think we've made really good progress, and we're confident that the required actions have been put in place and that we are now delivering on those. The ones where we still have some concerns, the red area, so we do still have very long waiting times, particularly for the autism assessment service, and longer waiting times than we would like for CAMHS. So there are associated improvement programs attached to both of those areas to try and reduce those waits. And then the area in amber there about the CCG having a thorough understanding at a senior level. Part of the reason why we're bringing this back here today is to make you aware, but also to ask your opinion on whether you feel appropriately cited on some of the SEND performance measures and how you would like to be updated on that in future. But I'll come back to that at the end. The next area was around commissioning arrangements. So this is to do with our joint commissioning responsibility with the local authority. Again, the areas in green are the ones where we think we've made good progress. The amber is where there's still some work to do, and the red is where we think we've still got a significant challenge. So that one there is about the number of children and young people who have an EHC plan but don't have a place in school. So the number has reduced. It was over 40 at the time of the inspection. That's now come down to 16. But as far as we're concerned, if there are any children who do not have a place in school, that's still a problem for us, and we are still working on that. Joint commissioning, in its sort of purest sense, did go a bit on the back burner during the pandemic because we were responding very operationally. We weren't doing as much of the strategic work, but that is now very much back on track, and we're making good progress against all the amber areas. So just to sum up, we do think we've made really good progress since the last inspection. That was delayed a little bit by the pandemic, as so many areas were, but we are back on track with the improvement programme now. What we need to do more of is gather evidence to demonstrate that that's actually having an impact on children, young people and families, and that we are improving their outcomes. So we're doing a lot of work, we're addressing a lot of actions, but is that actually making a difference to our children and families? We've been very clear all the way along with this improvement programme that we didn't just want a quick fix. We wanted to take the time to understand the root causes, to put in place really robust, sustainable plans that were fit for the future. So we know we haven't fixed everything yet. We know not everything is perfect, but we do have a plan for where we want to get to, and we are making progress on that journey. So the next step for us is to start bringing back some of our cases and projects. We're doing that through the SMT to progress our action plan and vision further. That's the end of the presentation, but the bit I would just like to go back to was the question about whether governing body feels well cited enough on this. If I can work out, I'll just stop sharing my screen. And there are a number of things that we could bring if it would be helpful. I'm not going to go through it in detail now because I'm conscious that you are pushed for time. So we have some quite, traditional numerical metrics around, waiting times for certain areas, be that CAMHS, neurodisability, wheelchairs, which we can share. We have the sort of softer, more qualitative data, so feedback from children, young people, families, schools, people working in the system. The other thing we thought it might be helpful to do, and which I think we've done before, is perhaps share some patient stories with you. And that's particularly helpful, I think, when we're thinking about impact and outcomes. So what difference is the work that we're doing actually making to people? So we'd be quite happy to bring back some patient stories for you in future, and some examples of the work we've been doing and how that's had an impact, if that would be helpful. And I'll finish there. Thank you.
Thank you, Sapphire. Again, very detailed presentation. I personally, one of my reflections there is I found that just the way you almost rag-rated some of those things that we needed to do was quite helpful in terms of very rapidly being able to see where we're doing quite well and where we need to improve. But I can see several hands have gone up, so I'm going to hand over to Brian first, please.
Thank you, Chair. Thanks, Terry. I'm Brian Hughes. I know I spoke at the start, but I'll speak towards the end as well. I'm Deputy Accountable Officer. Sapphire, thank you. It's really helpful to sort of see that journey and the journey that we've been on around the inspection, and the fact that we're still waiting for them to come in. So hopefully it will be the autumn term now. answer to your direct question at the end around what else would be useful, I think some of that qualitative stuff would be really powerful, because again, I have sat through some of the inclusion boards and seen some of the participants in it. And I think some of the stories are really strong. So I personally, more of the qualitative to support some of the quantitative data would be really strong, and I'd encourage and welcome seeing that, as I hope some of our members of governing body, all of our governing body would as well. So thank you. Thanks for the offer.
Thank you.
Okay, Nikki Bates, please.
Thank you, Sapphire. Yes, I think I would agree with Brian that I think we need to have some more patient stories, and also I would like to see the quantitative data and on how we're doing in a graphical over time. You know, with the number of children on the waiting list for the autism assessments and that kind of stuff. And I think that would be really helpful to share with our GP colleagues as well. But yeah, it was a very good presentation. Thank you very much.
Thank you.
Okay, thank you. Leslie, did you want to come in?
No, it's been covered by Brian and been covered by Nikki.
Thank you. Judy, please.
Yeah, thanks, Sapphire. Really helpful, and got a similar point to that's already been made around the qualitative, having the patient stories. But I'm wondering whether it would be really helpful if we offered the quality committee as the sort of forum for that to come to. Clearly, it could come to governing body also, but I'm wondering if we could have a more regular sort of input around that. And I know the committee's discussed this previously, wanting to be able to look at where are we at with SEND, etc. So I think that might be something, if the governing body agree, that we'd want to set up, Sapphire.
Thank you for the offer.
Yeah, thanks, Judy. I think it's a good offer. It'd be really good as well. And you've done this on other particular areas of work, Judy, is to bring the local authority to those discussions through the Quality Assurance Committee. Hopefully a bit more integrated working on this one will be helpful. Lee, please.
Hi, Sapphire. Thank you. That was a really great presentation, both quantitatively and qualitatively. It was good. Just in terms of assurance, really, I think it would be really helpful. You know, you've outlined what the issues are really well. It'd be really helpful to sort of understand what's being done about it and what the timeframes are. So we know that the waits are long in terms of CAMHS and neurodisability, and we've known that for quite a long time. And I don't know, as a governing body member, I'm not 100% clear what we're doing about it, and also what our sort of trajectory is in terms of addressing that and what our aspirations would be. So that'd be really helpful to sort of understand that, I think.
Okay, thank you, Lee. Any other bits of feedback specifically on what sort of information governing body would like to see? No, has that been helpful, Sapphire, in terms of the ask?
Yes, very helpful. Thank you. So I'll pick up some of that feedback with Kath outside of the meeting, if that's okay, and we'll come up with a plan for how we bring the right data back, and then I'll link up with Judy about how we take it through Quality Committee as well.
Fantastic. I've got one final reflection, and it may not be one for you to specifically need to answer here, but I'm just looking at the slide which is around the written statement of action part 4, specifically around the commissioning arrangements. And I just wonder, as we move into a more integrated system-wide way of working, whether that inspection might not just want to focus on the commissioning arrangements we've got in place, but more a system-wide response. It's just a reflection, again, not necessarily one for answering. Okay.
Thank you very much.
Thank you, Sapphire, for coming to join us. Thank you. I'll now move us on to part 4 of the agenda, which is an update from our accountable officer. Over to you, Leslie.
Thank you, Chair. Leslie Smith, accountable officer for the CCG. My updates on integrating care, and there are 2 papers that have been published that I want to bring to governing bodies' attention, which I think are important and that we should note. And they are in the noting pack at 17C2 and 17C3. So in the last couple of weeks, NHS England and Improvement published their design framework for integrated care systems, and alongside that, a document that outlines the employment commitment for staff in relation to the plan changes. So these documents have been published in advance of the legislation going before Parliament to establish ICSs on a statutory footing, and on the back of that see the dissolution of CCG. So they are quite important to us. And therefore, I just wanted to run through a couple of key highlights from the documents. And I am conscious of time, but there are a couple of things that I think are important to bring out. And I suppose the first one's to go back to the context. So these documents reaffirm the journey of both partnerships and of integration, which health and care systems and wider partners have been on since 2017, if not earlier. They reflect some of the learning from COVID pandemic and the last year, which builds on when we've been able to remove some of the barriers that sit between partners, and particularly between commissioners and providers. That's helped us to move faster with transformation and integration. So that's some of the context that lies behind the changes. The functions for ICSs are as we would expect in terms of tackling inequalities, minimising variation in access to care and the quality of clinical outcomes care, no matter where you live across South Yorkshire and Bassetlaw. Making the best use of the available resources, and about the NHS being a good partner, particularly to local authority colleagues, and supporting the journey to sustainability. So that's a bit about the context and the functions. The documents give us a bit more about ICSs and how they will work. So there's more detail in there on the health and care partnership. And I think that's quite important to note. We spoke about this last time at governing body. So the health and care partnership will be a committee between the NHS and local authority partners. Importantly, it will be a committee that is responsible for developing the strategy for integration. So I would expect that will be the strategy that builds on the 5 joint strategic needs assessments from every place, and the health and wellbeing board plans and each of our places, and therefore is a very important strategy, because if it works well, it's the thing that influences something that's very important to us in terms of the left shift and supporting that as we go forward. So health and care partnership responsible for that strategy, and then sitting alongside that we have an NHS statutory board which will be responsible for preparing the plan that delivers the health components of that strategy. So there's much in there about the makeup of the statutory board, which I won't go into in detail at this point in time. But I think some key things to be mindful of in there is the future flow of funds and resources will be through the statutory body as opposed to direct to places it is at the moment. And although the context that I mentioned was about taking out some of those barriers that have got in the way in terms of integration, clearly we still have in that statutory body a distinction between the funders of healthcare, so the commissioners and the providers. There is reference to contracts, there is reference to commissioning. We may do it in different ways, but that still continues, and I think that's important to note. The other key thing then that I wanted to pick out was, so ICSs formed from the partnership the statutory body, place partnerships and provider collaboratives. And I think place partnerships, it's important to note. So I know we're going to be doing some design work and discussions around our accountable care partnership, and we've mentioned that earlier in the meeting today. And I think the thing that I'd want to draw out for governing body members' attention at this point is the description of the place partnership is a partnership between the NHS, local councils, voluntary organisations, residents, people who access services, carers and families. So it's a partnership of those partners and constituents who will lead the design and delivery of integrated services. And I just think that's really important. So it's not a statutory entity, it's a partnership, but not a partnership of statutory bodies. It's much wider than that. And I think that's something that we should bear in mind when we're thinking about how that partnership evolves in the future and how it does that well, particularly in relation to the involvement of those wider groups. And the final component, so we've got the health and care partnership, the statutory board, the place partnerships and provider collaboratives. And again, the framework tells us a bit more about provider collaboratives in terms of how our providers, either across SYB, will come together, and they could take on resource and functions from an ICS to deliver improved outcomes for patients. So that might be the recovery of the elective work that's happening at the moment. But I think, again, it's important to note it is delegation with outcomes framework and accountability for delivering against outcomes frameworks. And therefore, the outcomes framework that we discussed earlier for Sheffield starts to become really important in that context. And similarly, at Place, we would expect our provider collaboratives to be coming together in many different ways. And we've already seen that in relation to primary care and mental health services, where we've got collaboratives working across the providers with primary care and with commissioners to take some of that work forward. So two final things for me to pick out: timescales. There are timescales in the document, so it was a bit like the firing gun in effect before the legislation went before Parliament. It signalled moving quite quickly to have designate appointments in place by the end of September to chair roles, to non-exec roles and to the chief exec roles, and then appointments to the other statutory roles, medical director, director of finance, nursing director by December. I think the important thing to note is that was the timescale last week. It was a really tight timescale. There were to be the second reading before the summer recess of Parliament to enable the legislation to go onto the statute book by February and be enacted for the 1st of April. That was hugely tight. It was hugely ambitious because if you remember back to 2013, legislation went on the statute books and then there was a year to prepare for that. So we were trying to do something which was go through a transition, not preempt the legislation, work with legislation that could change as it makes its way through Parliament, and actually be able to land in the changed world by the 1st of April. So that was the ambition. I think with the new Secretary of State for Health, I don't think we'll see the legislation going before Parliament this week. And therefore, I think this is really time critical because if it doesn't go imminently, it would be difficult to have the second reading before the summer recess. And that could have some quite significant implications. And I think significant implications for our people, which is just the last thing that I'll mention, because in publishing these documents 2 weeks ago, what we set out in there very clearly, or what was set out in there, was the distinction between over 90% of our staff having an employment commitment, which was really just a lift and shift of people and functions from CCGs into ICSs, but around 8% of staff across SYB not having that employment commitment. So ourselves as governing body members and people who are directly accountable to accountable officers. And I think we've known that for some time, but once you see it captured in black and white, it tends to have a different impact. So that's there now. That's out, and if we can't hold to that time frame, I think that will become increasingly difficult or challenging for us as we go through the year. So in terms of supporting our people, we've already started some listening events. So the ICS have hosted one with all of the CCGs and with the ICS PMO. Coming out of those events, there was an idea from Sheffield about a People's Hub. And I think I've just seen a communication that that's been established, where staff can bring their questions and have that sort of forum for open discussion. We pick up fortnightly at Staff Brief on the changes and the up-to-date position. And we've got a schedule of monthly drop-in sessions, again, where staff can come along and ask questions about where we're at and the latest position. And we had the first of those just days before the documents landed, which was really helpful. And the second of those in a couple of weeks' time, which again, I think will be helpful because we should be clearer on the timetable. So I think I will stop there, conscious of time, but I think that's just the key headlines from those two documents for noting.
Thank you, Leslie. Any questions or reflections for Leslie? Lee, please.
Hi, Leslie. Just for clarification, I wasn't quite sure what you meant when you were saying if the legislation's delayed, what that would then mean for the staff. Is there a link between those, or have I misunderstood it?
Yes, there is a link in my mind, Lee. So if it's delayed and we don't have a law by February, the CCG would continue as a statutory entity into next year. I don't think we've ever done these changes before in year. So I'm making the connection between when the documents were published 2 weeks ago with a tight timetable. You're at the point in systems where if you're going to have change, you do it in a minimum time scale and you try to minimize the disruption and give staff certainty. I think we're elongating that period, and I think that's tricky.
I'm really sorry, I still don't quite understand that.
Okay.
Or maybe you can't. I mean, maybe you can't say it. I don't know.
No, it's not that there's nothing that I can't say. I think if we've told people we're going through change, this is the timetable, and there'll be have a new employer, different organisations by the 1st of April, and today we're saying, well, actually, we potentially won't have passed that legislation.
Okay. So
we're extending that period of uncertainty.
So it isn't that there's any uncertainty about job security for people, for the majority of people.
No, no, it's not. I'm not saying we will be taking away employment commitments.
Yeah.
Probably I'm just saying people don't know where they're coming or going.
Okay. Well, we're used to that.
Yes.
Okay. I was just wanting to clarify about the employment commitment. So that's still in.
No. Mm-hmm.
It's the sort of finalisation of who you're working for.
Yeah.
You don't know when that's going to be. Okay, thank you.
Thank you, Lee. I think just sort of building on that, there's you don't know who you're working for as in terms of who is headed up on your payslip. But when we think about the employment commitment not being there for very senior members of staff, there'll be lots of people who don't know who they're going to be reporting to in the future, who's going to be leading, and that can create a great deal of uncertainty in those staff teams as well. So yeah, it does create an awful lot of uncertainty. I think Leslie and I have summed up a lot of this as watch this space. So any further questions? No. Okay, I shall move us then on to part 5, which are the reports circulated for noting, just recognising that we've covered some of those off in Leslie's update there. But does anybody wish to bring up anything on any of those reports? No. Okay. Any other business? Perfect. Okay. So recognising the time, I will not ask for 3 reflections, and also recognising that our next governing body meeting won't be until September. So I've just I've pulled out 3 things to reflect on here. Going back to the very beginning of our meeting, and just listening to Azra and her story, I think there's just a really important key message there, that as a CCG, we continue working with our local communities in tackling health inequalities and improving health overall. And I think that is a really important example, and a really good example of how working in different ways outside of perhaps your traditional statutory institutions really does make a difference on the ground. The second key reflection is just to bring up some of the significant work that's been undertaken in the mental health portfolio. I must say I was rather taken back by the detail and number of work streams being undertaken there to improve crisis care, and perhaps a more transformational way of bringing multiple partners together in an integrated way to affect change. And then my third and final reflection perhaps builds on the finance report and Leslie's integrating care update there, is that whilst guidance is slowly dripping through to us, I think as a governing body, there's still an awful lot of uncertainty in terms of financial position and future governance arrangements that we need to keep a very close eye on in the coming months. So I shall bring the meeting to a close now. Our next governing body in public will take place on Thursday, the 2nd of September at 2 p.m. Just to note, we do have a hold in the diary in case there are any urgent items of business in August, but I think everybody's hoping for a restful summer. So I'll bring the meeting to a close. So if I can ask Lucy to stop the recording, thank you.
You'll have to make me host, Terry, sorry.